Yes. Thank you.
Sachin sir, Gaurav sir has joined, so you can make him a co-host, sir. Dr.
Yes.
Gaurav Ganesh. Yeah.
Deepan, make Dr. Ganesh Gauravala co-host.
Done, sir.
Yes, yes. So we start. So welcome all you from IMA Pune. I'm Dr. Sachin Lakde. Yeah. Bus. Okay. Yeah. Ganesh, just 2 minutes. Gaurav, just 2 minutes. You can unmute yourself. And yeah.
We will wait for 5 minutes.
We'll wait for 5 minutes. Many of them are joining. So no, still there are 1 minute. We'll start the webinar. So you are not getting the audio. So good afternoon, everybody. Welcome from IMA Pune on this webinar from the AstraZeneca on prevention and management of complicated cardiovascular events. There are 5 talks from the expert speakers, and I request Dr. Varyani sir to have a word.
Very good afternoon to all of you, and welcome to this webinar on prevention and management of complicated cardiovascular events. We have a galaxy of speakers who will be talking on very excellent topics, which will be very useful in day-to-day practice. So without wasting time, we will begin with the webinar. And one thing I want to tell you, those your colleagues who are not yet members, please tell them to be a member of IMA, because we are having discounted membership fees from 1st June to 5th July. Thank you.
So to start with first lecture, Dr. Ganesh Gaurawala is a well-known interventional cardiologist from Pune. He's a senior consultant cardiologist working at Ruby Hall, Maine, as well as the Ruby Hall, Vanori, Pune. He has more than 10 years experience in field of clinical and interventional cardiology. He has completed his cardiology training at prestigious Amrita Institute of Medical Sciences, Kochi. He also has honor of both European as well as American Society of Cardiology, that's FESC and FCSIC. And he has performed more than 5,000 echocardiography that includes transesophageal echo and stress echocardiography. Apart from that, he has reported more than thousands of treadmill tests, Holter, and ambulatory blood pressure monitoring. So he has very vast experience in clinical cardiology. He has won Best Oral Abstract Presentation Award at CSI conference in 2016 research on the research work in coronary intervention. He has also been credited presenting his original research work on the advanced echocardiac study on RV apex and RV outflow tract permanent pacemaker lead positioning at Asia Pacific Heart Rhythm Society conference in 2013 at Hong Kong. So I welcome Dr. Gaurav Ganeshwala on his talk on delivering life-saving heart failure treatment modalities. Gaurav.
Yeah.
Gaurav?
So, yeah, can you hear me?
Yes.
So,
Gaurav,
yeah, I would first like to thank IMA and all the members of IMA to giving me this opportunity to have back-to-back talks in IMA meetings. So today I'm going to discuss about management of heart failure, and especially the focus will be on role of SGLT2 inhibitor dapagliflozin. So it is about delivering life-saving heart failure treatment. If we look at the heart failure, it's a major health concern, a growing public health problem with very high morbidity and mortality. if you look at the overall burden of heart failure, it is around 64 million of adult population worldwide. And there are two important concerns whenever we talk about heart failure. One is recurrent hospitalization. And if you look at the heart failure recurrent hospitalization, it is the #1 cause of hospitalization in elderly people more than 65 years of age. And hospitalizations are rising by almost 50%, and that is going to rise further in the next 25 years. If you look at the overall mortality related to heart failure, the mortality is again very high, and the 5-year mortality is as high as 50%. And with each and every hospitalization, the mortality significantly increases because they develop a lot of complications during this hospitalization. Some patients may develop renal failure, some may have arrhythmias, some patients are on inotropes because of hypotension. Some of them, they develop some infections, either community acquired or hospital acquired infections. So all these things leads to very steep rise in the mortality related to heart failure admissions. If we look at the natural course of heart failure, it has an insidious onset to start with, and many a times the heart failure, it has a silent course before patient develops the first symptom. So if we look at here, there are 4 stages of heart failure. Stage A, where patient is at high risk for heart failure, but without any evidence of structural heart disease and without symptoms of heart failure. Now, once it progresses to the stage B, patient has a developed structural heart disease, but there are no signs and symptoms of heart failure. Now it further progresses to stage C, and with stage C, patient has significant symptoms related to heart failure. And later on, the 4th stage is stage D, where patient goes into a state of refractory heart failure, which requires recurrent hospitalizations, requires specialized interventions, and sometimes may require a heart transplantation, and this stage has a very high mortality compared to other stages. If you look at the graph here, the curve here, patient remains stable without any symptoms for a long time. After that, probably there is one index event, either it is a myocardial infarction or some arrhythmia or some other insult which leads to hospitalization, and then there is a downfall which starts. And once the patient is in the full-fledged heart failure with symptoms and signs of heart failure, then the course is downhill. You can see here, patient develops hospitalizations. With each hospitalization, the quality of life worsens, risk of mortality increases, and slowly patient passes into the refractory heart failure stage, and where the treatment is very difficult, patient is highly symptomatic, and the mortality remains very high. So this is how a patient of heart failure passes through different stages. And that is why it is very important to identify the patients with heart failure at an earlier stage, so that the guideline directed medical therapy can be started at an earlier stage, and we can prevent the progression of symptoms, we can reduce the recurrent hospitalization, and we can overall have advantage of reducing the mortality in that particular patient. But despite of overall poor prognosis, there is a lack of urgency for early identification and initiation of guideline directed medical therapy. Most of the times it is because of lethargy of patients. Patient may consider that the symptoms of breathlessness or pedal edema or fatigue, they can be related to increasing age. Sometimes they feel that the breathing difficulty may be related to conditions like asthma. So overall, there is a lethargy on the part of patient. So they don't reach to cardiologists, they don't reach to the medical facility at an earlier stage. So if we see, almost 40% of patients have heart failure symptoms up to 5 years before diagnosis of heart failure. Many a times we see that patient comes to medical facility, but then, sometimes we also miss the diagnosis of heart failure. if patient has a documented low ejection fraction, then it is easy to diagnose heart failure, which is called heart failure with reduced ejection fraction. However, there are other forms of heart failure where the ejection fraction remains preserved, or the ejection fraction is normal or near normal for a very long time. So in such condition, it is little difficult to diagnose a case of heart failure. So that also sometimes lead to delay in the initiation of guideline directed medical therapy. Now, if we see, almost 75% of patients are diagnosed with heart failure after an admission. So many times patient gets admitted for heart failure and then only they are diagnosed to have heart failure. And even though we have very good guideline directed medical therapy available for management of heart failure, the overall data from data from India and other parts of the world, it very clearly tells us that most of these patients are on suboptimal guideline directed medical therapy. Either they are receiving at in suboptimal state, or sometimes they are not receiving the guideline directed medical therapy at all. And there is overall 30% mortality rate 1 year after heart failure hospitalization. So what are the guidelines saying about management of heart failure? So this is a very popular European Society of Cardiology 2021 heart failure guidelines. And if we look at the management of patients with heart failure with reduced ejection fraction, heart failure with reduced ejection fraction means the ejection fraction should be less than 40%, and patients must be having signs and symptoms of heart failure. So the first line drugs or class 1 drugs, they include AC inhibitor or ARNI, which acts on the renin-angiotensin-aldosterone system, beta blockers, which mainly act on the sympathetic nervous system, aldosterone antagonist, which inhibits the aldosterone pathway, and we have the relatively new group of drugs which are called SGLT2 inhibitors like dapagliflozin, empagliflozin, canagliflozin. They have different kind of mechanism, and they also are quite useful in management of heart failure with reduced ejection fraction. And of course, the loop diuretics like torsemide or furosemide, they are used for removing the excess fluid from the body. That means whenever there is a fluid retention or congestion, these loop diuretics can give significant symptomatic benefit. And these are considered as class 1 medications for management of heart failure with reduced ejection fraction. Now, there are some selected cases where the ejection fraction is less than 35% and the QRS duration on ECG is broad, more than or equal to 130 milliseconds, and patient is in sinus rhythm. So in such cases, if we use a special kind of pacemaker, which is known as cardiac resynchronization therapy, and along with that, that also has a function of defibrillator. So there is an implantable defibrillator along with the cardiac resynchronization therapy. So whenever the QRS duration on ECG is broad, that means patient has significant dysynchrony between the ventricles, between the atria and ventricles, and these are the patients who are going to benefit with CRT-D implantation. But remember, this is for a small amount of patients where they fulfill the criteria of low ejection fraction and QRS duration more than 130 milliseconds. But there are certain patients who have low ejection fraction, but the QRS is not so broad. In such cases, for prevention of sudden cardiac death, they can be considered for AICD implantation. AICD is a special kind of pacemaker which has a function of defibrillation. So whenever patient develops ventricular tachycardia or ventricular fibrillation, this smart device, it identifies the abnormal rhythm and it gives a shock to control the abnormal rhythm and makes the rhythm stable. So this gives some time to the patient for reaching to the hospital or other medical facility. And later on, this can be identified and we try to know what are the reasons why patient has developed the arrhythmias and why he received a shock. And based on that, we optimize the management for that particular patient. But these are very smart devices, and in selected patients, it can be really life-saving, and with CRTD, sometimes we can see the improvement in the pumping capacity of heart as well. Now, if patient has persistent symptoms, despite of all this therapy, then we have to go for the class 2 medications, which we'll be discussing later. Now, similarly, we have 2022 AHA ACC guidelines for management of heart failure, which again tells us that establish the diagnosis of heart failure with reduced ejection fraction, address the congestion with loop diuretics, and then initiate the guideline directed medical therapy in individuals who have low ejection fraction, less than 40%. So these are the 4 pillars of heart failure management, or class 1 therapy for management of heart failure. That includes SGLT2 inhibitors like dapagliflozin, empagliflozin, beta blockers, which are cardioselective beta blockers like metoprolol, carvedilol, bisoprolol, and aldosterone antagonists, which includes spironolactone and eplerenone. For many years, we had AC inhibitors or ARB. In AC inhibitors, we had enalapril, ramipril, perindopril. In ARBs, the only ARB which is recommended for management of heart failure with reduced ejection fraction is valsartan. But in the last 1 decade, we have a wonderful molecule with us, which is called ARNI. So it is a combination of valsartan with sacubitril. So this particular drug has advantage over AC inhibitors or ARB, and it has a proven benefit in terms of reduction of mortality and reduction in hospitalizations related to heart failure. Now, since we are discussing about SGLT2 inhibitors today, in patients who are having symptomatic heart failure with reduced ejection fraction, SGLT2 inhibitors are recommended to reduce hospitalization for heart failure and cardiovascular mortality, irrespective of presence of diabetes. So it is considered as class 1 with level of evidence A. So it's a very strong indication in patients with heart failure. And why it is mentioned here that it is irrespective of presence of type 2 diabetes, because if you can recall, SGLT2 inhibitors were initially introduced as a oral hypoglycemic agent. It has a significant natriuresis and glycosuric effect, which leads to reduction in the HbA1c and the blood sugar levels. So that is how it was initially introduced as a drug for management of diabetes. But later on, we came to know about the beneficial effects of SGLT2 inhibitors, which are over and above the natriuretic and glycosuric effect, and it has a very significant effect on the myocardium. So it improves the calcium metabolism in the myocardial cellular level, and that improves the overall energy metabolism in the myocardium, and that is very beneficial in management of heart failure. Apart from that, it has many other pleiotropic benefits in terms of reduction of atherosclerosis, improving the endothelial function. It reduces the afterload, and there are many other added advantages of SGLT2 inhibitors. So initially it was tried in diabetic patients, but later on we have a very strong data even in non-diabetic patients. So this is again a very important slide. 2021 European Society Cardiology and Heart Failure Association consensus recommendation. It states that SGLT2 inhibitors are component of foundational therapy for all heart failure with reduced ejection failure patient phenotypes. So if you see here, these are the 4 pillars of management of heart failure: SGLT2 inhibitors, beta blocker, AC inhibitor, ARB or ARNI, and aldosterone antagonists. We see different kind of patients in our practice. Some patient may have slow heart rate, some may have heart rate which is very fast, some may have very good blood pressure where we can give all the medications without any limitations or restrictions, because many of these medications, they have hypotensive effect, especially the ARNI, beta blockers, and to some extent aldosterone antagonists also has some effect in reducing blood pressure values. So if the blood pressure of that particular patient with heart failure is on the lower side, let's say it is around 90 or 100, in such cases, we may not be able to step up the dose of beta blocker or ARNI or aldosterone antagonist very rapidly. But remember, SGLT2 inhibitors has no contraindication related to hypotension because it has no significant effect on the blood pressures. And even if patient has tachycardia or bradycardia, SGLT2 inhibitor can be very safely given in each and every patient with heart failure with any kind of pulse rate. Even somebody who has chronic kidney disease or hyperkalemia, it can be given up to eGFR of 25. So dapagliflozin has significant data up to eGFR of 25. Empagliflozin has data up to eGFR of 30. So except for the end-stage renal disease, it can be very safely given in patients with CKD and hyperkalemia. Whether patient has atrial fibrillation or sinus rhythm, SGLT2 inhibitor can be used any of these patients. Now, if we go to beta blocker, somebody who has bradycardia, beta blocker cannot be given easily. Somebody who has PR interval prolongation on ECG, beta blocker is contraindicated. If blood pressure is very low, below 90 millimeter of mercury, again, beta blocker has to be given very cautiously. Similarly, ARNI has some contraindications if blood pressure is very low. Patient has CKD and hyperkalemia, again, ARNI has to be given very cautiously. Aldosterone antagonist cannot be given in patients with hyperkalemia. Again, it has some effect on blood pressure. So if blood pressure is very low, spironolactone or eplerenone should be given very cautiously. Diuretics can also bring down the blood pressure. So somebody who has borderline or low blood pressure, it has to be given with very care. It should be given very carefully. So out of all these drugs, only SGLT2 inhibitor is one group of medication which can be given irrespective of blood pressure value, irrespective of pulse rate, and irrespective of type of rhythm. So it can be given in each and every patient with heart failure if eGFR is more than 25. Now going on to the landmark trial of dapagliflozin, which is known as DAPA-HF, and that looked into dapagliflozin and prevention of adverse outcomes in heart failure. So this particular trial had more than 4,744 patients, and all these patients had ejection fraction less than 40%, elevated NT-proBNP and eGFR more than 30, and they were randomized to either to dapagliflozin or placebo group. And remember, this particular trial had patients with diabetes and without diabetes. So anybody who has heart failure, irrespective of diabetes, they were included in this particular study. If you look at the baseline characteristics, the NT-proBNP level was quite high, 1,437. That is a very high value of NT-proBNP. That tells us that patients must be in advanced heart failure and they must be having a lot of symptoms related to heart failure. If you look at the echocardiographic ejection fraction, the ejection fraction was again very low, 31%. Almost 55% of patients were non-diabetic. So 45% diabetics and 55% non-diabetics were included in the study. And when we look at the eGFR values, almost 41% of patients had eGFR value less than 60. That means that also tells us that this group of patients were quite sick and they were randomized either to dapagliflozin or to placebo. And what we learned from this particular study was there was a 26% relative risk reduction of cardiovascular death or worsening of heart failure in dapagliflozin group compared to placebo. When we look at the cardiovascular death, there was 18% relative risk reduction and all-cause mortality was reduced by 17%. The worsening of heart failure and heart failure related hospitalizations were reduced by 30% in dapagliflozin group compared to placebo. And two other very important informations what we received from this particular study was, if you look at the number needed to treat, it was as low as 21. So if you treat 21 patients with dapagliflozin, you are able to avoid 1 cardiovascular mortality if you treat this patient for more than 2 years. So 21 patients treated for 2 years, you can prevent 1 cardiovascular mortality with dapagliflozin. That is a very remarkable number. And another important finding here is, if you look at the curves, they are separating very early. So when we start patient on dapagliflozin, the actual benefit in terms of reducing heart failure hospitalization or reducing the cardiovascular mortality, it is seen as early as 28 days after starting dapagliflozin. So that is again very important. We have seen many studies where we see benefits of mortality, benefits of hospitalization, but the benefit starts very late, after 6 months or after 1 year. But this is one molecule where we see benefits as early as 28 days after starting of therapy. So that is again very remarkable and a wonderful number. Now, when you look at the subgroup analysis, both diabetics as well as non-diabetics, they have equal benefits in terms of reducing mortality and heart failure hospitalizations. So overall population, the hazard ratio is 0.74. In diabetics, it is 0.75, and even in non-diabetics, it is 0.73. So irrespective of diabetic status, dapagliflozin perform better compared to placebo. When we look at the side effect profile, the side effects are comparable in both the groups, whether it is dapagliflozin or in placebo. So many a times we are worried about risk of hypoglycemia or risk of dehydration or volume depletion. Sometimes we are also worried about the ketoacidosis. In one of the SGLT2 inhibitor trial with canagliflozin, there was increased incidence of limb amputation. But however, when we look at this particular trial with dapagliflozin, they are all comparable to placebo. There are no major side effects with dapagliflozin. Now, the another molecule in SGLT2 inhibitors group is empagliflozin. But when we compare data from DAPA-HF with dapagliflozin and EMPEROR reduced with empagliflozin, if you look at the benefits, the heart failure hospitalization reduction is seen in both the trials with both the SGLT2 inhibitors. But when we talk about the mortality benefit, dapagliflozin is ahead of empagliflozin. Similarly, all-cause mortality is also better with dapagliflozin compared to empagliflozin. And new onset diabetes, if you see the reduction of new onset diabetes cases, again dapagliflozin is ahead of empagliflozin. So overall, dapagliflozin has performed better in DAPA-HF trial compared to empagliflozin in EMPEROR reduced trial. Now, this was about heart failure, mortality, and hospitalizations. But when we look at the benefit of dapagliflozin in the cardiorenal complications, we have, it is very well known that heart failure is associated with cardiorenal syndromes, and they share some of the similar genetic predispositions and environmental risk factors as far as heart failure and kidney failure is concerned. In patients with heart failure, there is chronic low cardiac output, there is vascular inflammation, arterial and endothelial calcification, which leads to initiation of kidney damage. And when they have over time a chronic hypoperfusion, raised venous pressure due to increase in the pulmonary capillary wedge pressure and pulmonary artery pressures, there is a rapid progression of chronic kidney disease related to sclerosis and fibrosis. And this is how a patient with chronic heart failure develops chronic kidney disease over time. And apart from that, the anemia, other metabolic abnormalities, volume overload, that also adds into progression of kidney disease. And there is a vicious circle. As the kidney disease progresses, the heart failure also progresses, and patient becomes more symptomatic, and they progress into the higher stage where they turn into refractory heart failure. Now, we have wonderful data with dapagliflozin even in CKD population. So if you look at the DAPA CKD trial where we had more than 4,300 patients. And if you look at the inclusion criteria, adult population, eGFR of 25 to 75, urine albumin creatinine ratio was 200 to 5,000, and they were on stable doses of ACE inhibitor or ARB for more than 4 weeks. So in patients who were either diabetic or non-diabetic, irrespective of diabetic status, they were included in the study, and the eGFR was 25 to 75, and they were randomized to either dapagliflozin 10 milligram or placebo. And in this particular trial, we saw that there was a significant 39% relative risk reduction of composite of sustained more than 50% eGFR decline, end-stage kidney disease, or renal or cardiovascular mortality. And again, the number needed to treat was very low, only 19 patients. You treat for 2 years, and you can have one reduction in the primary endpoint. So this very clearly tells us that if we start dapagliflozin in patients with CKD, where eGFR is more than 25%, we can reduce we can slow down the progression of kidney disease. We can prevent the progression to end-stage kidney disease. Overall eGFR decline is also slowed down, and overall mortality related to cardiovascular and renal failure is reduced. All-cause mortality is reduced by 31%. Now, irrespective of heart failure history, so whether a patient has heart failure or not, if patient has CKD and they are treated with dapagliflozin, they have significant reduction in the primary endpoint. That means the progression of CKD is slowed down, and even the cardiovascular and renal death is reduced. Similarly, whether a patient is diabetic or non-diabetic, the benefits are seen in both the subgroups if we treat them with dapagliflozin. So when we look at the data from DAPA CKD and EMPA kidney, so EMPA kidney trial is with empagliflozin. The DAPA CKD results are better compared to EMPA kidney results. However, you have to always keep in mind that both are different trials. There can be some variation in the baseline characteristics as well. But however, the data with DAPA CKD is more impressive compared to empagliflozin. There is a 39% relative risk reduction in primary endpoint, 31% reduction in the mortality, 29% relative risk reduction in cardiovascular death or heart failure hospitalization. Now, this was about the data of dapagliflozin in heart failure and CKD. But what should be the sequence of therapy? How to start guideline-directed medical therapy? So there are two ways of starting therapy. One is conventional therapy, which we have tried for many years. If you remember, the ACE inhibitors came into market in 1990s, and beta blockers were also available in the same time. So for many years, the ACE inhibitors and beta blockers, they were the main cornerstone of treatment for heart failure with reduced ejection fraction. Now, with availability of molecules like ARNI, that means sacubitril valsartan, beta blockers, aldosterone antagonists, and the newest of the lot, which is SGLT2 inhibitors like dapagliflozin and empagliflozin. If we start all the 4 first-line therapy, the mortality is less, survival is better. And if we start the patients on all the 4 drugs together, compared to only 2 drugs which are started in the conventional therapy, patient has overall increase in the lifespan by 6.3 years. So if we start all the 4 drugs as early as possible, patient is likely to live 6 years more compared to somebody who is on conventional therapy. Now, what are the limitations of conventional therapy? This is how we have treated patients of heart failure for many years. So the first line drug was ACE inhibitor like enalapril or ramipril, or in some cases valsartan. We try to start the medicine, try to up titrate it to a good dose or maximally tolerated dose. Then we try to add beta blocker, we up titrate the dose of beta blocker. Later on, we try to add spironolactone or eplerenone. If patient does not get adequate benefit with AC inhibitor or ARB, in that case, we change from AC inhibitor to ARNI, and later on we add SGLT2 inhibitors. So this process takes a very long time, and many a times patient is only on 1 or 2 medications for many months after a heart failure hospitalization. So this delay in starting therapies, it very clearly increases the morbidity and mortality in the initial 30 days of heart failure hospitalization. And this is the period where the number of hospitalization and the mortality is very high. So with the conventional protocol, the time period for initiation of therapy was a very long period. And that is why many of the patients, they did not receive the maximum benefit of the guideline directed medical therapy. Now, this is the new expert proposal of for sequencing the heart failure therapy, which is completed in 4 weeks. So in the step 1, somebody who is admitted with heart failure or somebody who comes to our OPD with heart failure, we try to start 2 medicines. One is SGLT2 inhibitors. Remember, SGLT2 inhibitor does not have any major effect on pulse rate or blood pressure or even creatinine or potassium levels. So it can be safely started in most of the patients with heart failure. Beta blocker is important because beta blocker has an added advantage of preventing sudden cardiac death due to ventricular tachycardias and ventricular fibrillations. So we try to initiate these 2 drugs as early as possible, most of the times during the hospital admission. Later on, if the blood pressure is fine, the potassium and creatinine and EGFR levels are fine, in that case, we try to add ARNI as early as possible. So one important change here is ARNI is preferred over AC inhibitor or ARB. So they have become first line drug. And along with that, we try to add aldosterone antagonist in next couple of weeks. So within 1 month, we try to start all the 4 pillars of heart failure management: beta blocker, SGLT2 inhibitors, ARNI, and aldosterone antagonist over 4 weeks or 1 month. So this gives us the maximum protection in the initial 1 month after hospitalization. Now, another concern is whether all dapagliflozins which are available in market are same as Forxiga, which is the original research molecule from AstraZeneca. So time and time we have seen that the pharmaceutical equivalence is not equal to bioequivalence, and bioequivalence is not equal to therapeutic equivalence. So remember, having same content in a pill does not guarantee you the similar pharmacological effect and similar side effect profile, because remember that there is a slight change in the bioavailability of the medicine. If the bioavailability is high, in that case the chances of side effects are high, and if the bioavailability is low, then in that case patient may not get the expected benefit out of the medical therapy. So even a slight change in the bioavailability can reduce the effectiveness of that particular therapy. Now another important thing, if you look at the data from Forxiga is the original molecule. It has approval from US FDA, EMA, DCGI, and it is used in more than 130 countries compared to a very limited approval for other dapagliflozins. All the major trials are conducted with the original research molecule from AstraZeneca. We don't have any RCTs with the other generic dapagliflozins. So these are again important factors. And over years, we have seen that with other molecules like statin, whenever we used the generic statins, we did not get the similar benefits in terms of reduction of vascular events when we compared it with the original research molecule of rosuvastatin or atorvastatin. Similarly, in patients who were treated with generic clopidogrels or generic ticagrelor, again, we did not get the similar benefit. The risk of stent thrombosis was higher in generic clopidogrel or generic ticagrelor compared to the original research molecule. And with that, I'll just summarize the my talk. So dapagliflozin has transformed the outcomes by providing life-saving benefits. SGLT2 inhibitors, they are recommended in each and every patients with heart failure with reduced ejection fraction unless they are contraindicated. Guideline-directed medical therapy use includes dapagliflozin in very early course of therapy. DAPA-HF trial demonstrated significant benefits of dapagliflozin in primary composite outcome across the subgroups, whether they are diabetic or non-diabetics. DAPA-HF demonstrated 18% relative risk reduction in the cardiovascular mortality and 17% relative risk reduction in all-cause mortality. DAPA-CKD demonstrated 31% relative risk reduction in all-cause mortality. And in the last part, a mere bioequivalent generic may not necessarily lead to the same therapeutic effect as the innovator research molecule. And always remember, bioequivalence is not equal to therapeutic equivalence. Even a slight change in the bioequivalence can have unpredictable effects in terms of safety and efficacy. Thank you. With that, I will conclude my talk. Thank you.
Thank you, Gaurav, for your brief presentation on the DAPA-HF trial, dapagliflozin as an original molecule from the AstraZeneca for Forxiga and its role in heart failure with reduced ejection fraction. Now, I request Dr. Varyani sir and Virendra sir to felicitate Dr. Gaurav.
Thank you very much, Dr. Gaurav sir, for your excellent talk. Please accept our token of appreciation. IMA Uparna sir.
Thank you. Thank you very much.
Ganesh, here is the IMA diary for you.
Thank you.
Thank you.
There is small announcement for all delegates. All delegates are requested to fill the Google form. It's with your WhatsApp message. It's there, and even on the email, you can fill that form. You have to fill that form for the MMC purpose. Next, I request before that, Deepan, can you make Dr. B.B. Harshe sir co-host so that he's the next speaker? He will be ready with his presentation. Yeah. So next speaker is Dr. Pratibha Phadke, madam. She's a well-known physician in Pune city. She's consultant physician at Dinanath Mangeshkar Hospital, practicing for last 35 years. And she's also postgraduate guide for DNB medicine students. She has special interest in diabetes and particularly gestational diabetes. So to hear from the Dr. Pratibha Phadke, madam, reduce the pressure from kidney using dapagliflozin.
Good afternoon, everybody. You have heard a lot about dapagliflozin in heart failure. Now let us turn towards kidney. So as we know, India has the largest number of diabetic patients, and about 40% of diabetic patients eventually land up in some sort of kidney problem, either acute kidney disease or chronic kidney disease, landing up to end-stage kidney disease and eventually to either dialysis or kidney transplantation. Can we do anything for these patients? So initially, management of diabetes was sugar-centric. So everybody was after controlling sugar by any and all means. As times have changed, we have started looking at other factors like complications like cardiovascular events, cerebrovascular events, as well as kidney. So now all guidelines tell us to evaluate every patient's kidney risk and heart risk at the time of diagnosis and eventually every time at the follow-up. So let us start with a patient. This is a typical patient we see in any OPD. It's a 70-year-old patient with type 2 diabetes for last 12 years and is on anti-diabetic treatment, metformin, sulfonylurea, DPP-4 inhibitor at maximal doses. He is under treatment for hypertension and under treatment for lipid-lowering agents like statin. He is also on ACE inhibitors for hypertension and calcium channel blocker. When we investigated him, his HbA1c was 7.8. His estimated GFR was 32 ml, and his urinary albumin creatinine ratio was 800 microgram. He was asked to come for follow-up, and after 8 months, when he came for follow-up, he had 2 kg weight gain, and his GFR was declining by 5 ml, and his urinary albumin creatinine ratio had increased by 20%. Can we help this patient? Where this patient is going to land further? So as we know, burden of atherosclerotic disease is high in diabetic patients. Atherosclerotic disease like coronary artery disease, stroke, peripheral vascular disease. Burden of non-atherosclerotic disease like left ventricular hypertrophy, various arrhythmias like atrial fibrillation, sudden cardiac death, then arterial calcification, valve calcification like aortic sclerosis, hemorrhagic stroke, and many other non-atherosclerotic diseases are also high in diabetic patients. So here it shows that prevalence of heart failure in patients with CKD. So in CKD, without CKD, prevalence is less than 10%. In stage 1 and 2 of CKD, you can see it has increased to 25%, and it further increases as we go further into further stages of CKD. The risk of mortality is also increased as CKD progresses, irrespective of patient whether he has diabetes or patient is non-diabetic. The risk of mortality, according to lowering of eGFR and high albumin creatinine ratio, is similar in patients with diabetes and without diabetes, in non-diabetes as well as diabetic patients. Here we see that heart failure is the most common cardiovascular comorbidity in patients with any stage of CKD. So at any stage of CKD, generally the patient doesn't die of advancement of CKD, but the patient dies because of heart failure generally in any stage of CKD. So it is very important to prevent cardiovascular mortality by preventing progression of kidney disease. So here we can see what are the stages of CKD by estimated GFR. So G1 is normal or hyperfiltration stage where estimated GFR is more than 90. G2 is mildly decreased, that is between 60 to 89. Stage 3 is divided into 3A and 3B. In 3A, it is mildly to moderately decreased eGFR, which is above 45 and less than 60. In 3B, it is up to 30. And in G4, which is severely decreased estimated GFR is below up to 15. And when we call it end-stage kidney disease, GFR is less than 15. We have to see both estimated GFR as well as albuminuria in each patient of either hypertension or diabetes. So normal or mildly increased albuminuria is less than 30 milligram per gram of creatinine. A2 is moderately increased, that is 30 to 300. And A3 is severely increased, that is more than 300 up to nephrotic range of proteinuria. So what can we do in such patients? Are there any trials? So multiple molecules have been tried. You can see here that vitamin D analogs, glycosaminoglycans, erythropoietin stimulating factors, ACE inhibitor and ARB combination. So everything has been tried to prevent further progression of a patient to chronic kidney disease. What is proved is there are trials.
I found this on the web for better and ARB combination. So everything has been tried to prevent further progression of chronic. What check?
So what is proved is ARBs, ACE inhibitors, and SGLT2 inhibitors. Another molecule which is there in the guideline is finerenone. It is a non-steroidal mineraloreceptor antagonist. Benefit in patient with progressive increase in estimated GFR. So it was presented in by last speaker, DAPA-CKD. It was dapagliflozin was tried in patients of CKD. Number which was included in this trial was 4,304. 2,000 patients received dapagliflozin and around 2,000 received placebo. 68% patients were diabetics and 32% patients were non-diabetics. So it was tried in non-diabetics also. Inclusion criteria was diabetes. Inclusion criteria was age more than 18 years, eGFR 25 to 75 ml per minute, and albumin creatinine ratio of 200 to 5,000. So all patients were in high risk of progressing to end-stage renal disease. So there was 39% relative risk reduction where GFR decline of more than or equal to 50%, and end-stage kidney disease or CV deaths were the endpoints. So there was 36% relative risk reduction in patients with type 2 diabetes and 50% relative risk reduction in patients without type 2 diabetes. So it has shown benefit in both type 2 diabetes patients and non-diabetic patients who are in stage 1 or 2 of kidney failure and who had significant albuminuria. This trial was stopped early because the results were so convincing that it is helping these patients and it is showing benefits in admissions for heart failure also. So this trial was stopped early. So about safety of dapagliflozin in this trial, it was well tolerated and adverse events were rarely required to stop the drug. So in this slide, it is showing primary outcome according to CKD stage. So overall primary outcome events per 100 patients year was 4.6%. In stage 4 kidney disease, it was 11.1%. Stage 2 and 3, 3.7%. In end stage kidney disease, overall events were 2.5. Stage 4 and stage 2 and 3, 9.2 and 1.6. In CV death reduction, overall 1.4 events. In stage 4, 2.3, and in stage 2 and 3 of kidney failure, 1.3. Dapagliflozin showed slower eGFR decline. Here we can see comparison with the placebo. It showed slower decline in eGFR. The cause of kidney disease was different in these patients. Diabetic nephropathy was there in some patients. Hypertensive nephropathy or ischemic nephropathy was there in some. Glomerulonephritis and unknown causes. Overall, in all causes, dapagliflozin showed improvement. So here it is compared in patients with various stages of diabetes, like severity of diabetes. In all, there was significant improvement with dapagliflozin. There was 36% relative risk reduction. Change in albuminuria, here you can see in this slide, in both the patients with type 2 diabetes and without type 2 diabetes. In type 2 diabetes, there was around 35% reduction in urinary albumin creatinine ratio. You can see clear difference between placebo and dapagliflozin. And in patients without diabetes, about 14.8% reduction in albuminuria was seen. Albumin creatinine ratio was seen. Also, as we have seen in earlier talk, there was benefit for admissions for heart failure too, in patients who didn't have history of heart failure, and as well as in patients who had history of heart failure. Cumulative incidence of AKI in patients who already had CKD also reduced with the use of dapagliflozin. Here it is shown as compared to placebo, there is significant risk reduction in AKI, hazard ratio being 0.68. So what are the safety outcomes? How many patients discontinued the drug? Dapagliflozin was discontinued in 12.7% and placebo was discontinued in 14.4%. Discontinuation because of adverse event was only 5.5% in patients getting dapagliflozin. Serious adverse events were only 29.5% amongst this 5.5%. What were the adverse events? Amputation, diabetic ketoacidosis was 0, amputation was only 1.6%, fracture only 4%, and renal related adverse events were around 7.2%. Major hypoglycemia was only 0.7%. Volume depletion, which we are worried because dapagliflozin causes natriuresis and diuresis, it was only 5.9%. And serious adverse event because of volume depletion was only 1%. And Fournier's gangrene, which was 0%. So about significant side effects were not there, and discontinuation was only in 5% of the patient. Here it is this slide I think you have already seen in with the first speaker. Here DAPA CKD and IMA is compared with DAPA. There is no direct head-to-head comparison with between the two SGLT2 inhibitors, but both the trials are DAPA CKD and IMA kidney trial are compared here. And as you can see, DAPA scores in all three measures: all-cause death, composite CV death, or hospitalization for heart failure. Everything is significantly high and impressive with DAPA. Here, hospitalization for heart failure reduction, there was 30% reduction with dapagliflozin and about similar percentage reduction in empagliflozin. but death reduction was significantly high with dapagliflozin. This slide also you have seen earlier. All-cause death reduction is also 17% with dapagliflozin and 8% in empagliflozin, which was not significant. And new onset diabetes, reduction in new onset diabetes by 32% and 14% with empagliflozin. And quality of life score was improved with dapagliflozin, plus 6.1 plus minus 18.6, and here 5.8 plus minus 0.4. So significant difference regarding DAPA and EMPA. I think we have maximum experience of using DAPA, and we are comfortable in using dapagliflozin. So how does this dapagliflozin actually act? What does it do to the kidneys? It reduces the glomerular pressure. Then because of that, it stabilizes albuminuria, reduces albuminuria. Then there is neurohormonal improvement. It reduces intrarenal RAS activity, reduces sympathetic nervous system activity, so reduces blood pressure and indirectly benefits kidney. It reduces inflammation and fibrosis also. There is reduction in inflammatory markers when we use dapagliflozin. In similar fashion, finerenone also acts at this stage. There is improved tubular oxygenation, reduced solute transport, increased oxygen delivery, and increased erythropoiesis. So renal ischemia is reduced, hemoglobin is improved, and hematocrit is also improved with the use of dapagliflozin. And that's how it overall improves renal perfusion and renal function. So let us go to actual management. So when a patient comes to you with reduction in estimated GFR, and if his sugars are not controlled in a diabetic patients, you have two choices, either to use SGLT2 inhibitor or GLP-1 analog. If eGFR is significantly reduced, you have evidence with SGLT2 inhibitors only. So once you initiate SGLT2 inhibitor, you have to check the patient's creatinine in first 4 weeks. After first 4 weeks are over, if there is reduction in increase in serum creatinine or reduction in eGFR by more than 30%, you assess the patient's volume status, whether patient is euvolemic, hypovolemic. You have to assess that. If you feel that patient is volume depleted, check for acidosis. These patients in a setting of like in summer when their intake is low, additionally if they are taking some diuretics, they are likely to develop volume depletion and acidosis, and then you have to stop treatment and see for if there is euglycemic ketoacidosis. When you use SGLT2 inhibitor, sugar levels might be normal, but still patient will be in ketoacidosis. So you have to keep a close watch on these patients. And if you find that they are in euglycemic ketoacidosis, you have to stop the treatment. Suppose you see that there is increase in serum creatinine and volume status is normal, you can look for other causes of increase in creatinine, like if there is new onset urinary tract infection or any other cause, and continue with SGLT2 inhibitors. Suppose there is no increase in creatinine, then you can safely continue SGLT2 inhibitor. Suppose there is volume depletion is not there, but as I said, you check for other causes, hold SGLT2. If there is no improvement in serum creatinine, you stop SGLT2. But if there is improvement in serum creatinine, you can restart SGLT2 inhibitors. So basically, you have to monitor the patient for various things. They are likely to get genital infections too. So if there are genital infections with SGLT2 inhibitor, which is common in postmenopausal female, and if in patients above age of 60, 65, where prostate and obstructive uropathy is common, you have to watch for genital infection. Most genital infections like vulvovaginitis can be easily treated with single dose of fluconazole, and you need not discontinue SGLT2 inhibitor. If there is worsening, then you should discontinue SGLT2 inhibitor, treat that infection, and restart SGLT2 inhibitor. You should educate your patient regarding genital hygiene. When you, at the beginning of starting of therapy, you should educate them regarding adequate hydration too. And you should tell them about various risks, how to watch for dehydration, how to watch for genital hygiene. Sometimes SGLT2 inhibitor have been associated with increased risks of UTI. If the UTI is mild, like just cystitis, you initiate treatment for cystitis. If patient is not recovering, you should discontinue SGLT2 inhibitor, treat the cystitis completely, and then restart SGLT2 inhibitor. If it is complicated urinary tract infection like pyelonephritis or urosepsis, then stop the SGLT2 inhibitor, reassess the patient after the episode, and then you can reinitiate SGLT2 inhibitor. But if the patient is getting recurrent episodes of genital infections, that is more than 3 episodes or more than 5 episodes of UTI or recurrent pyelonephritis, you should stop using SGLT2 inhibitor. You have to educate the patient regarding protein intake. Generally, we recommend 1 gram per kilogram of body weight per day in a normal patient. In CKD patient where GFR is less than 30, you should tell the patient to limit protein intake to 0.8 gram per kg. Then reduce salt intake, generally not more than 5 grams of common salt. Tell the patient regarding risk because of obesity, risk because of hypertension. Try to optimize blood pressure, try to reduce weight, stop smoking, and various other things which can progress kidney disease. Then you have to look for additional effects of CKD like hyperphosphatemia, hyperuricemia, hypocalcemia, and you have to treat those two to complete the treatment for CKD. So current guidelines, what are the current guidelines in a patient of CKD with diabetes? If HbA1c target should be around 7% to prevent delay in progression of all microvascular complications, including diabetic kidney disease. So if patient is old, has a low risk of developing cardiovascular mortality, then you should change the target of HbA1c in a higher age group patient, like above 80, where there is less risk of developing cardiovascular event, or you are not much worried about that, but you are more worried about hypoglycemia, which will have effect on his cognition. So HbA1c target should be changed according to comorbidities, and if patient has low life expectancy, then you should change the HbA1c target. If there is CKD and hypertension, for patients with CKD stage 1 to 3 and hypertension, every patient should receive S inhibitor or ARB to reduce the risk of end-stage renal disease and albuminuria progression. You have to watch for hyperkalemia If hyperkalemia develops, you have to stop ACE or AR. If the patient has congestive heart disease or heart failure with or without chronic kidney disease, the recommendations are same level of care should be advised to these patients, because as we have already seen, heart failure patients have high risk of developing chronic kidney disease because of various reasons, like low perfusion of the kidneys, then low hemoglobin, then high sympathetic nervous system activity. So they should be offered same care as you offer for any CKD patient. Antiplatelet therapy should be given to patients in whom there is risk of atherosclerotic events. So almost all patients receive antiplatelet therapy too. NICE guidelines also recommend same thing.
I found this on the web for or give the patient has congestive heart disease or heart failure with or without chronic kidney disease. The recommendations are same level of care should be.
Sorry. What are the ADA standards of care for treatment of patients with CKD? If CKD with albuminuria more than 200 is there, use of SGLT2 inhibitors is preferred regardless of baseline A1C. So even if A1C shows that it is controlled, even if it is 6.5, you can reduce other anti-diabetic drugs, but add SGLT2 inhibitor. And you should individualize the target, as I have already said, and preferably SGLT2 inhibitor should be immediately started. You can also start GLP-1 receptor agonist with proven CVD benefit if SGLT2 inhibitor is not tolerated or it is contraindicated. That means if patient already has pyelonephritis, you cannot use SGLT2 inhibitor, then you are allowed to use GLP-1 receptor agonist. And if A1C target is above our desired target, then you can use either, if you are using SGLT2 inhibitor, you can add on GLP-1 receptor agonist and vice versa. If patient already has CKD, that is eGFR is less than 60, then you can use both the drugs, as I've said, SGLT2 inhibitor or GLP. SGLT2 is preferred because of lot of evidence of reduction in progression of end-stage kidney disease with SGLT2 inhibitor. You can add GLP-1 analogs too, to reduce A1C level and for their CV benefits over and above SGLT2 inhibitor. So if a patient comes to you with when his eGFR is more than 30 and his albumin creatinine ratio is more than 200 and has heart failure, what are the contraindications for use of SGLT2 inhibitor? Genital infection risk, diabetic ketoacidosis, and foot ulcers. And if the patient is on other immunosuppressants like say azathioprine or methotrexate, you should avoid using SGLT2 inhibitor, or you should use them with proper care with close monitoring. So you can start with low dose of SGLT2 inhibitor like dapagliflozin and educate them regarding sick day protocol. If they are getting vomiting, loose motion, they should hold the dose of SGLT2 inhibitor that day. Avoid dehydration. Avoid use of SGLT2 in perioperative period. So all this you have to explain to the patient. So you should educate the patient regarding the risk of hypoglycemia if the patient is on insulin and sulfonylurea too, along with SGLT2 inhibitor. Then explain regarding, as already explained, volume depletion risk with concurrent use of diuretic when the patient has other risk factors for volume depletion. And if the patient has history of acute kidney injury in recent past, you should educate regarding volume depletion symptoms too. This dapagliflozin expands the other uses of dapagliflozin, which are proved by various trials like DECLARE-TIMI, DAPA-HF, and DAPA-HF and DAPA-CKD. And in these various trials, number of patients have been large number of patients have been included with and without type 2 diabetes. And all these trials have shown significant benefits for CKD patients and for cardiovascular death and reduction of hospitalization for heart failure too. So which dapagliflozin shall be preferred? The last speaker has already explained to you regarding pharmaceutical equivalence is not bioequivalence, and bioequivalence is not therapeutic equivalence. So ideally, we should prefer well-researched and original brand where you have experience of using it for a longer period. Already this slide has also been shown where generics and biosimilars have no similar effect in efficacy. They have increased side effects in many cases. So we should go to the original molecule. So in such patients where there is high risk of mortality, and if you can prevent that with guideline prescribed drug, you should use that drug. So Forxiga should be preferred over other dapagliflozin, which have no scientific evidence regarding various studies done. Again, there are two trials where generic statin was compared with original statin. This also was shown in by the earlier speaker. So generic statins have higher percentage of events than original statin. Similarly, with regarding instant thrombosis, generic antiplatelets had increased evidence of instant thrombosis. So let us go to our case. Our patient had grade 3B CKD and category A3, that is high level of albuminuria as per risk stratification. So intervention is required for to reduce further progression or worsening of CKD. So as we should tell him regarding intensive glycemic management, we should also add drug which will reduce further progression to end-stage kidney disease. So we'll add dapagliflozin to this patient. We will monitor this patient for rise in creatinine, for volume depletion, for development of normoglycemic ketoacidosis. And if everything goes all right, we will continue dapagliflozin, and eventually we'll see that his albumin creatinine ratio has been stabilized and his eGFR decline has reduced. If still there is decline in eGFR, we have another molecule to add, that is finerenone, and that way we can reduce the total risk of development of CKD. Thank you for patient listening, and thank you IMA for giving me chance to speak.
Thank you, madam. You have explained very well about the dapagliflozin role in chronic kidney diseases, and also the bioequivalence Forxiga, which is the original molecule, how its importance in managing the CKD with diabetes. Any questions? Delegates are requested to post in the chat box. And I request Dr. Varyani sir and Dr. Virendra sir for felicitation of Dr. Pratibha Phadke madam.
Thank you, Dr. Pratibha Madam, for your excellent talk. Please
Thank
accept
you,
our token of appreciation from IMA Pune. This is IMA Upper Madam.
Thank you, sir.
Madam, this is IMA diary, financial diary for you.
Yeah, thank you.
Thank you.
Thank you.
Thank you, madam.
Thank you.
So, Dr. Kiran Kharat sir has, we welcome Dr. Kiran Kharat sir. He is a MMC or observer for today's webinar. He's also joined online. And now I request next speaker, Dr. Harshay sir. Dr. Harshay sir is consultant diabetologist, well-known diabetologist in city of Pune and Maharashtra. He's consultant diabetologist in Pune Hospital and Research Center. He's secretary, Diabetic Association of India, Pune branch. He is participating in many state and national, international diabetic conferences as delegate and as well as a faculty. Conducted and designed public education and awareness program in diabetes, including stage show, drama, lectures, public speech, articles in media. He has organized and conducted diabetic education program, CMAs for medical health professionals. He has also authored a book in Advances in Diabetic Management, a case compendium in 2015, and Sadico's International Textbook on Diabetes in 2017. Recipient of Scroll of Honor and by PHFI for consecutive 7 years for conducting certified course in diabetes for medical health professional. So I request Dr. Harshay sir to give his talk on change the lens of to manage the diabetes. Sir, you need to mute yourself. Sir, you need to mute yourself. Sir, unmute yourself, sir.
So we need to make him co-host, I guess. He is not the co-host. BPRC, sir.
Deepen, make co-host.
Bhaskar Harshay, yeah, sir is there. But
Sir, sir, you need to make Sir, you can share.
Yes, thank you.
Slides, sir. Share your screen, sir.
Yes, I'll share. Yes.
Deepen, can you help Harshay sir in sharing the screen?
No problem. It's okay. Can you see my screen now?
visible, sir.
Yes, sir, visible.
And am I audible to everyone?
Yes, sir.
Yes. So, first of all, good afternoon, everybody, and thank you to you all organizers and
Sir, we can hear you, sir.
Yeah. So good afternoon, everybody, and thank you all organizers as well as AstraZeneca for inviting me for presenting an interesting topic, change the lens to manage diabetes. As already my earlier speakers, Dr. Gaurav Ganeshwala and Pratibha Phadke, change your lens, and you are looking through the lens, looking ahead only dapagliflozin to treat the patient. And I expect that you go for your practice and start prescribing dapagliflozin, but be aware, don't prescribe it to the fewer or patients other than having other disorders. Hello? Hello, can you hear me?
Sir, your voice is not clear. Slides are not visible, sir. Yeah, now slides are visible, sir.
Okay, shall I stop my video so it will improve the situation? Is it okay now?
Yeah, sir. Much better, sir. You can go ahead, sir.
My word, yes. What I was sharing that my earlier speakers, Dr. Gaurav Ganeshwala and Pratibha Phadke, have already changed your lens, and now you are looking. Dapagliflozin is the only drug for the treatment of any patient, but be aware that don't use this drug in febrile illnesses or infectious diseases, and very selectively use this drug in restricted metabolic disorders and atherosclerotic cardiovascular diseases. So, as these are the this is your dapagliflozin day. Let us go further. Some of the slides were already been shared to you by earlier speakers, but I'll try to make interesting this talk. Here is a teacher whose occupation is sedentary and is as expected is obese. His BMI is high. He is 54 years old and presented with some medical history of type 2 diabetes for 5 years, dyslipidemia for 6 years, hypertension for 6 years. He also had diabetic retinopathy and he recurrently getting hypoglycemic episodes. So that clicks in the mind. Probably he have some underlying kidney disorder or some underlying liver disorder. We have to find out why he's getting the hypoglycemic episodes in his life total scenario or his setup. His BP was well controlled. BMI is expected on the higher side. HbA1c is 7, and his EGFR is 55 ml per minute per 1.73, and USCR is not done initially. His current treatment is on metformin 500, sitagliptin 100, ramipril 5, hydrochlorothiazide 12.5, and rosuvastatin. And his lipid profile is cholesterol is not in target, LDL is also not in target, HDL is also below target, and fasting triglycerides are also above the target. However, is it really important to address do the albumin creatinine ratio during the albumin creatinine ratio and CKD assessment in every patient? The answer is yes. And this is because if you look at the statistics, the prevalence of kidney disease in 17.2% in adult population, and usually this diagnosis is made somewhere in between stage 3, stage 4, and stage 5, where practically the disease becomes irreversible. One second. Interestingly, REVEAL CKD study shows that the greatest of stage 3 CKD is highly prevalent and significantly undiagnosed, even in high-risk patients. And the greatest opportunity to arrest the progress of CKD lies within stage 3 population, which is highly prevalent in primary care, in a patient which you treat in your clinical setup. So stage 3 CKD up to 96% remain undiagnosed in our busy OPD setup. And KDIGO recommended screening of CKD even in a high-risk patient, and this is because in cardiovascular disease, you will surprised to know that undiagnosed stage 3 CKD, the proportion will be 53 to 95%. In hypertensive patient, the same is 59 to 95%, and in type 2 diabetic patient, it is 51 to 94%. So all these risk categories, the proportion always remains higher on side, more than 50%, and it is mandatory that you have to find out whether the patient attending your OPD is having any stage 3 CKD or not. And this is important because the same study tells you from the study of 27,000 patients in US NetX database, and they evaluated that EGFR decline before and after CKD. surprised to note that if you don't diagnose before diagnosis, the eGFR decline is much faster. But once you diagnose that patient is having stage 3 CKD, probably the patient and the treating physician, they are becoming more aware and they are modifying their treatment accordingly. And the fall in eGFR probably much lesser. So if you diagnose eGFR early, you have, CKD early, stage 3 CKD early in your practice, it is going to definitely help to arrest the progression of patient towards the end-stage kidney disease. This slide has already been shown to you, and we'll just plot our patient where he lies. So as we have seen that he is having moderately, mild to moderately decreased eGFR, and it is 45 to 59. So if we consider only eGFR is an abnormal, and he doesn't have albuminuria, it's normal or mildly increased, his assessment or his CKD related complication risk is mild to moderate. But when you add the moderately increased proteinuria in this scenario, and you see that USCR is 60, then the risk becomes more. So with eGFR and in USCR assessment, patient risk of CKD related complication becomes more higher and higher. And you have to place the patient where he lies on the heat map. And it is now your duty or your aim that you have to prevent his albuminuria, or you try to reverse his albuminuria or arrest it or the deterioration of kidney function further to avoid him to enter in the end-stage kidney disease. However, you manage the patient, either conventionally or intensively treatment. Of course, there is relative risk reduction in intensive treatment with respect to blood pressure, systolic blood pressure, HbA1c, lipids, and prophylactic aspirin, ACE inhibitors, and vitamin C and E supplement. There is risk reduction of 0.44, relative risk reduction 0.44% between the conventional intensive treatment. But still, after intensive treatment also, the residual risk of kidney damage or CKD complication, it still remains. So it is on the time that aggressively approach to this CKD disease very, very important. So when you treat either a diabetic patient or a non-diabetic patient, you start, you think of organ protection, and in diabetic patient, always look beyond the glucose control and act early and protect the kidney and heart disease accordingly. It's a team approach, and various guidelines in 2022, KDIGO, kidney disease improving global outcome treatment algorithm for the patient with type 2 diabetes and CKD is like this. Of course, there is no substitute for lifestyle modification. Then the first line therapy, either a metformin or SGLT2 or both together. But metformin is contraindicated where your eGFR is less than 30 or patient on dialysis because of risk of lactic acidosis. If your eGFR is less than 45, you have to reduce the loss, that is you are in stage 3B. And in for SGLT2 inhibitors, if your eGFR is less than 20, don't initiate the drug in that patient, and patient is on dialysis, you have to discontinue it. Other supportive drugs or other add-on drugs to control the hyperglycemia, you can safely use GLP-1 receptor agonists, DPP-4 inhibitors, insulins, and second generation sulfonylureas, glycosides, about glitazones, and you have to be very, very cautious because they precipitate the fluid retention and failures also. And alpha glucosidase inhibitors, apparently they look relatively safe in using in the CKD patients. So ADA standard care treatment of patient with type 2 diabetes and CKD. If you have patient, two categories of patient: CKD where albuminuria is more than 200 milligram per gram, and CKD without albuminuria. In both, in patient with albuminuria, the only first drug of choice preference is only for SGLT2 inhibitor. That's all the data or the evidence sees. And SGLT2 inhibitors, subsequently you can add GLP-1 receptor agonists to reach the targets, and with a proven CVD benefits, and you can use this combination. You have a chance use other than SGLT inhibitors. If SGLT2 inhibitors are contraindicated, you can use GLP receptor agonist, and you can add the SGLT inhibitors subsequently. But if patient is without albuminuria, you have this option really open. But patient with albuminuria, always think first of using SGLT inhibitors, and second drug will be the GLP-1 receptor agonist. But if no albuminuria, then you have a choice to select the drugs. Now the $1,000,000 question: which SGLT2 inhibitors? Various drug trials on various Cana, DAPA, and empagliflozin have conducted. Out of that, declare IMA 58 trial with dapagliflozin, which represents the population seen in general practice and which leads to prevention and type 2 diabetic complications. And here, how I'll show the comparison. In empiric population, the basic EGFR is more than 30. In canvas population also, basic EGFR is more than 30. And declare the population which is included in this study is EGFR more than 60. And that's why secondary prevention, that is after the event or after the onset of CKD or atherosclerotic cardiovascular disease, in empiric population, the EGFR is a little bit set at points at a little bit lower limit. So that's why 99% population is suffering from atherosclerotic cardiovascular disease. In canvas trial, 65% and in declare only 40% or 40.6% suffering from a symptomatic atherosclerotic cardiovascular disease. And first degree prevention is better studied in declare trial because around 60.4% of population having multiple risk factors, and in this population also, whether the dapagliflozin effective or not has been studied and compared with the placebo. And the event rates had been studied with placebo. With empiric trial, they are practically the major adverse coronary event rates are much higher as compared to the declared trial. That is, they are up to the 24.2% level. So review the dapagliflozin data in type 2 diabetic patients. If you multiple glycemic and extra glycemic benefits, you see the for the dapagliflozin various studies at different trials of HbA1c from lower to higher. Definitely the HbA1c reduction also gradually increases when if the DAPA is added to metformin in the treatment. Similarly, the studies have also been conducted as a monotherapy with SGLT2 with DAPA and compared with the placebo. And similarly, add-on therapy has also been compared. And at the baseline, fairly constant HbA1c level, you get better reduction with the better glycemic control with dapagliflozin. The same case about the weight. In normal weight person, the weight reduction is not very significant with dapagliflozin. However, in the overweight patient who is having a BMI more than 40 kilograms per meter square, there is definitely 3.4 kg weight reduction has been observed, which is definitely beneficial also. Another interesting study in hypertensive patient, the DAPA efficacy against placebo has been tested for systolic blood pressure and diastolic blood pressure, and where whose the DAPA definitely shows the reduction in systolic blood pressure by 10.4 milliliters of Ag. And if the study has been conducted on a population who are on existing ACE inhibitors, ARB, and who are also on having triple drug also combination, ACE, ARBs, and say calcium channel blockers, people have added the DAPA and showed that addition of DAPA further contributes further reduction in systolic blood pressure. So these are extra glycemic or effects of dapagliflozin. Now the effect is really sustainable or not? That is again a question. So if you use DAPA and if effect doesn't lie, even sustain for more than 3 months, 4 months, then what's the use? A 50 to 1 year study, reduction of HbA1c or statistical has been studied, and it shows that the HbA1c reduction were statistically non-inferior to glipizide. So if the sustainability is also good. Similarly, after the 4 years, the reduction in body weight was 4.38 kg, which the placebo-corrected trial has been studied. Similarly, the reduction of blood pressure also maintained up to the 4 years, and there is also lower incidence of hypoglycemia with the drug. So fear of hypoglycemia of all anti-diabetic drugs is very less as compared to the other OHs, and it is very less with the DABA. If you study the natural course of any patient presents with the multiple severe risk factors, he becomes adult, he get exposed to various risk factors like smokers, he becomes overweight, he becomes hypertension, dyslipidemic, then there is a chance of increasing, at some point of in life, he get diagnosed as type 2 diabetic. And there is a chance of increasing risk of heart failure, CKD, then the cardiorenal events occur, then repeated events occur, and finally the death. So can we arrest? Yes. So can we arrest this progression and can we delay this curve? So yes, with lifestyle modification and modification with targeting specific conditions, you have a better outcome in such patients. So is there any drug available for the prevention, or is there a drug available for therapeutic window? And DAPA gives the perfect solution for this. This conclusion has come from the study that dapagliflozin slowed the renal disease progression in type 2 patient with relatively good renal function. So even in good renal function, you start using the declared trial proves that the renal function and the patient who are having eGFR more than 60, or that is the mean GFR is 85.2, that's near normal, and microalbumin is 30.2, that's also near normal. And the placebo control trial shows that the DAPA, yes, so definitely proven have a better effect in number of reducing the number of events in next 5 years. Similarly, the renal benefit also demonstrated across the eGFR subgroups in patients and without or with established CV disease. So if your eGFR is more than 90, it's a normal or near. Then if it is stage 2, that is a 60 to 90, or stage 3 less than 30, and other stages also. And also in patient having CV rates, patient having established cardiovascular disease or multiple risk factor, the DAPA, use of DAPA in such population favors, and it definitely reduces the untoward event rates in future life. Similarly, albuminuria category, the deterioration from albuminuria is definitely arrested or regressed by use of dapagliflozin, and there is a higher chances has been confirmed with use of dapagliflozin that patient can get converted from macro to normo, normo to micro, and micro to normo albuminuric patient. So this trial also supports that DAPA is really a wonderful tool which we have available, so we can use safely in CKD patient at earlier stages also. Is this drug is safe? Yes. Various side effects, that treatment emergent side effects, treatment required to discontinue the drugs, major hypoglycemia, ketoacidosis, amputation, fractures, acute kidney injuries, volume depletion, genital infection, UTIs, corneas gangrene, bladder cancer. All these side effects are very, very less, and they're as compared with the placebo tablet. So DAPA is very, very safe to use in all such populations who are at early. So this explains that the DAPA is a drug which acts on pump, that is a heart failure, pipe, that is the atherosclerosis of the blood vessels, and filters, that is the kidney. So in a population, if you look at the type 2 diabetes population in DECLARE trial, the patients with multiple risk factors, they are around 60%. Then atherosclerotic cardiovascular disease, but no prior MI, and prior MI less than 2 years ago. So all this population, all this subset contributes around 40.6%. Major adverse coronary events are definitely reduced in these 3 subgroups or 2 subgroups, that is patient with prior MI less than 2 years or patient with prior MI. However, the study doesn't support that atherosclerotic cardiovascular disease, but no prior MI, and multiple risk factors, whether this major coronary events or major adverse cardiovascular events are reduced or not. The trial doesn't conclude anything. However, in heart failure, cardiovascular disease, heart failure events, and also renal events, this drugs is very helpful, and it covers the heart failure, it protects the kidney. So that's why the title is Pumps, Pipe, and Filter. The dapagliflozin covers it all. So it is a window of opportunity where you can use this drug in a multiple risk factors, and major adverse coronary events may not be prevented. It may be equivocal results, but you can definitely reduce the future cardiovascular disease and heart failures, and you can definitely protect the kidneys. So DAPA has definitely a good role of the protection of kidneys. My earlier speaker has already been shown the slide DAPA CKD overview, and overall, definitely the outcomes, the cardiorenal outcomes in this DAPA CKD trial, they've shown that there is 39% risk reduction of events occurring like EGFR decline, end-stage kidney disease, or renal or CV death with a dapagliflozin. All-cause mortality also has been reduced. And interestingly, the trial stopped early due to overwhelming efficacy. Usually, the trials usually stop because of some adverse events, but this has been stopped due to overwhelming efficacy of the trial. And the first renal outcome study showed robust benefit on all-cause mortality in patients with or without type 2 diabetes. Heart failure, CV death benefits in CKD patient that is consistent of heart failure, and we declare demonstrated cardiorenal protection across the spectrum of diabetic kidney disease severity. So DAPA becomes now becoming a first choice in management of type 2 diabetic patients. Now, DAPA is really one step ahead in cardiorenal protection as compared to the other VADs. So if there is a comparison between the Fosgiga and empagliflozin. It's a powerful glycemic control, yes, efficacy is seen, but however, new onset diabetes or in pre or non-diabetic population, then the reduction with cardiovascular events and heart failure events, the all-cause mortality events, heart failure in primary prevention, and CV deaths, the Fosgiga or the dapagliflozin scores first as compared with the empagliflozin. So which dapagliflozin shall be preferred? So obviously the which agent do you prefer? So that says is dapagliflozin. Now when you are in a practice, patient always comes to you, no, the Fosgiga is very costly brand and it's innovative brand. I can't afford it. Doctor, shall I take a generic brand? The answer lies here. So this is somewhat a concept that pharmaceutical equivalence, earlier speaker has shown this slide, so I have not elaborated. So pharmaceutical equivalence is a pharmacokinetic study where it studies where the drug, how the drug enters, get absorbed, gets metabolized, gets excreted, and bioequivalence incorporates the pharmacodynamic study. So what is exactly action on the target tissues, and whether these two actions has to be studied and not, and mere bioequivalence or mere bioequivalent generic not necessarily the same therapeutic effect as the inhibitor. So what happens, how you get approval for these generic drugs? So if you want to approve get your approval generic drugs, the generic drugs should show the bioavailability either less than 20% or more than 25% bioavailability in this range only. If the drug is bioavailability lesser than this, there is a efficacy of the drug is reduced. If the bioavailability is less than 20% and it's still lesser, then the drug efficacy is reduced. And if the bioavailability is more than 25%, then the innovative drug or the innovative drug, then it can responsible for the untoward side effects. So on both ways, it is very difficult to comment on the generic drug where these drugs are allowed or not. If you study the key attribute, various key attributes and compare with Fosgiga with other dapagliflozin, so active pharmaceutical ingredient is dapagliflozin propanediol and monohydrate. The active pharmaceutical ingredient is not known in other dapagliflozin. Formulation 100% crystalline, other dapa may be crystalline amorphous. And this approval is also by various authorities and international authorities and countries. But the other DAPA get approved from the state FDAs and DCGA. There's the DAPA and dapagliflozin or Forxiga is backed up by declared DAPA HF and DAPA DK study, and no such RCT studies have been done. These studies are also conducted for a longer duration time, and the studies, whatever conducted on the generic medicine, the duration which we don't know. And bioavailability and bioequivalence trials, the number is only 16, and with concern to Forxiga, 21 phase 2b3 trials, and the patient number is also known to us, that is 9,339. So it's a robust evidence you have. And one important point, that bioavailability trials mean the generic drug is compound is compared with a similar other compound. Only bioequivalence trial, the generic drug is compared with the innovator's brand, and the comparison is available for the study. So how much weightage to offer such trials is again $1 million question. So many data points are definitely show the differences between the original and generic drug. You save the money on spending on generic drugs, but in long term you are going to lose a lot of money. But you invest more initially on the innovator brand, and you definitely cut down your further expenses and definitely prevent your organ damages. This is because definitely a compared innovator generics, in case of statins also, there is a well proved that innovator and generic statins are compared, and they have shown that higher probability of suffering cardiovascular events with generics and as compared to innovators. Similarly, the stent thrombosis has been studied, and 1,054 patient clinical information systems were performed, and they have found within 30 days how many stent thrombosis cases occurred, and the overall the incidence is 0.38%. Out of that, they have studied. They have said that there is 2.7-fold increase in definite 30-day ST or stent thrombosis events with generic clopidogrel use. So this is a trial on clopidogrel use, and this generic clopidogrel. And after exclusion of 3 historic controls, because this is all data collected on the histories, that is the non-compliance, marked thrombocytosis, and defined reasons for with a defined reasons for stent thrombosis, they found that 3.2-fold increase in 30 days stent thrombosis with generic clopidogrel. So friends, always recommend our patient that don't take generic medicines, go with the innovator brand. And if still he insists that I want to take a generic medicine, definitely the decision is left on the patient, and you explain that there are chances you may have better or you may have some other problems. So here is again our patients, and now how will plan this patient? So this patient is grade 3 and category 8-2 as per risk stratification. Earlier intervention is required to prevent further worsening of CKD, progression of end-stage kidney disease. Intensive glycemic management does not eliminate the risk of diabetic nephropathy. He also had evidence of diabetic retinopathy, which has to be going hand in hand with increasing evidence of dapagliflozin. Was chosen to add it to this patient, and the quality of evidence remains the same with the original innovator molecule. So thank you for the patient's hearing, and thanks a lot. Thank you.
Thank you, Harshay sir. You have briefed the role of dapagliflozin and how it has role in the management of diabetes, and various views, various studies you have highlighted, and importance of those studies in the day-to-day practice. Now, I request Dr. Varyani sir and Virendra sir to felicitate Dr. B.B. Harshay sir.
Thank you, Dr. Harshay sir, for your excellent talk.
Thank
As
you.
a token of appreciation, please accept IMA Uparna, sir.
Yes, yes. Thank you, sir. Thank you. We'll meet definitely in IMA and I'll come there.
You are most
Thank you.
welcome, sir. And this is the financial diary for you. Thank you,
Yes,
sir.
yes. So I have to rush fast to collect that to manage my finance.
Yes.
Yes, sir.
Yeah.
Thank you.
Nice token of praise. Thank you.
Thank you, Harshit sir. Thank you, Virendra sir and Variani sir. Now I welcome Dr. Sumit Agarwal sir. I think he is there. He has joined the meeting. Sumit, you can start sharing your slides meanwhile.
Yeah.
he is on.
Are the slides visible, sir? I think I've shared from my end.
Your slides are visible.
Perfect.
Just to
So-
introduce Dr. Sumit Agarwal, is well-known young physician in city of Pune, very dynamic physician. He's practicing mainly in the
Karvenagar.
Karvenagar
Yeah.
and Varje, and he's attached to Mai Mangeshkar Hospital, and he has his own hospital, Agarwal Hospital. So to hear from him, rosuvastatin evidence in primary and secondary prevention cardiovascular events. Over to Dr. Sumit Agarwal.
Thank you, Lakade sir. Thank you for the kind introduction. Thank everyone, AstraZeneca and all the attendees who have been patient enough to listen to all the topics. So I'll be talking about rosuvastatin evidence in primary and secondary prevention of cardiovascular events. This is a 37-year-old male working in a corporate company, attended ER with severe headache, discomfort in the chest. His past history, he's diabetes and hypertensive in 10 years. He's non-alcoholic, smoker 15 years with diagnosed dyslipidemia 2 years back, and he's on regular medications for the same. His family history: father has a multivessel coronary artery disease. CABG was done 20 years back, and he's on regular medications. Lifestyle: frequently taking outside food at least 2 to 3 times in a week. So this guy is average. Looks like an average IT guy, 37-year-old with diabetes, hypertension, dyslipidemia, occasional non-alcoholic and smoker with a strong family history of ISD. So on examination in the ER, his pulse rate was 99, his blood pressure was 140/80, his respiratory rate was 22 per minute, his saturation was 89 on room air, his BMI is 26. His blood examination showed a triglyceride of 210. His HDL was 31. His creatinine was 1.2. His LDL is 168. His HbA1c is 8. His old ABPM 3 months back shows a morning surge of systolic blood pressure. Spot cardiac biomarker troponin is negative. His random blood sugar was 190, and his ABG parameter showed a metabolic acidosis with pH of 7.2. He is currently on telmisartan with hydrochlorothiazide 20 plus 1, 12.5, amlodipine 2.5. He's on rosuvastatin 5 milligrams, metformin 500 once a day, and empagliflozin 10 mg OD. His ECG showed sinus tachycardia with ST elevation in 2-3 AVF, suggestive of inferior wall MI. So, how to approach this patient? So we have to re-evaluate the patient for definite or likely STEMI or ACS, development of hypertension, development of subsequent bradycardia, signs of left ventricular failure or pulmonary edema, extracardiac vascular disease or anomalies, his jugular venous distension, development of cardiogenic shock, heart sounds, any development of murmur, any gallop. We'll have to check his ECG again to see for any development of Q waves or changes in T waves, if any, changes in XT segment in following 6 to 12 hours. His biomarkers need to be reported at his troponin IT to see if it shows any elevation. So, how to treat this patient now? So, immediate intervention, general supportive management. Pharmacological intervention will consist of nitrates, sublingual preferred one. Beta blockers can be used if there is no bradycardia. Dual antiplatelet has to be initiated immediately. Anticoagulation therapy has to be started, and high intensity statins have to be initiated. Evaluation further with invasive coronary angiography or coronary revascularization if required, and PTCA with a drug-eluting stent if required has to be done. For long-term management, again, supportive care along with pharmacological interventions. Pharmacological interventions will consist of beta blockers, depending on the patient, double antiplatelets, antihypertensive, nitrate statins. So, angiography was done in this patient. which showed the LAD 71% and 76% in OM3, but adequate collateral supply in OM3. So what are the stages? What are the stages of atherosclerosis? So long before this patient had events, his atherosclerosis had already begun. So endothelial dysfunction begins decades or years before actually a cardiovascular event actually occurs. So primary prevention has to be started decades, even in the healthy artery, in a normal artery. Secondary prevention can be started with endothelial dysfunction, which can be subclinical in atherosclerosis, whether there is a stable plaque, or in unstable plaque where there is plaque rupture. And tertiary prevention, of course, in patients with a complication like acute coronary syndrome, thrombosis, infarction, tertiary prevention has to be started. So level of risk factor, even in subclinical atherosclerosis, we have to start with secondary prevention. So we should evaluate the patient for dyslipidemia management. Dyslipidemia treatment, existing medications is rosuvastatin 5 mg per day. Need aggressive statin management guidelines, prospective, and prevent rupture of vulnerable plaque. So hello, am I visible?
Hello, sir. Slides are not moving. We are still on first slide.
You're seeing the first slide.
Your slides are not moving, Sumit, and voice is also not clear.
Just a minute, sir. Are they moving now?
Now the slides are moving, Sumit.
And is it full screen?
No, sir.
Yeah. But just make it presentation view. Slideshow.
I did it, but then there's some issue on myself. I think the slides are only visible in minimized state. In slideshow mode, they are not visible, right? I did a slideshow mode. Is it visible now?
Or can you just stop and share again?
I'll do that. Yeah. They are visible in minimized screen, right?
Yeah, they are visible in minimized screen.
But in a full screen, they are not visible.
So,
are you okay with such minimized screen? Because I think full screen.
try for slideshow again.
I'll do that. Yeah. Is it visible in full screen?
Yeah. Now they
Yes,
are
sir.
visible in slideshow. So you can go ahead, Sumit.
Just a minute. Okay. Yeah. Okay. So superior LDL reduction along with plaque regression helps achieve additional 12% reduction in MACE. So this patient, he was on rosuvastatin 5 mg per day. For better LDL reduction, superior LDL reduction along with plaque regression will help to reduce the MACE event by almost 12%. Usher is a new era of LDL-C, further intensively reduce the lipid goal patient with ASCVD at a very high risk. So new or revised concept, more intensive reduction of LDL-C across CV risk categories for secondary prevention in very high risk patients, LDL reduction of more than 50% from the baseline, and an LDL goal of less than 55 mg per deciliter are recommended. So this is for very high risk. The LDL goal has to be less than 55. For patients with ASCVD who experience a second vascular event within 2 years, not necessarily of the same type or as the first event, while taking maximally tolerated statin therapy, LDL of less than 40 has to be considered. So for patients who have already established ASCVD and who is having a second episode of any vascular event in less than 2 years, despite being on fully tolerated statin dose, his LDL goal has to be less than 40. For patients with very high risk, a LDL reduction of more than 50% from the baseline and an LDL goal of less than 70 are recommended. For individuals with moderate risk, a LDL goal of less than 100 should be considered. And for individuals with low risk, a LDL goal of less than 116 may be considered. It is recommended that a high intensity statin is prescribed up to the highest tolerated dose to reach the goal set for specific levels of risk. So we need to evaluate the risk of each patient, and then a goal has to be set. At a very high risk CV, at a very high CV risk, a goal of 55 mg per deciliter or more than 50% LDL reduction has to be set. This is ESC 2019 guidelines for dyslipidemia management. For moderate risk, in which the score is more than 1 and less than 5. So this is the young patients with diabetes, age less than 35 or age less than 50, duration of diabetes less than 10 without any risk factors. This is a moderate risk patient, and the goal can be kept up to 100 mg per deciliter. For a high risk person, where marked elevated single risk factor, in particularly the total cholesterol more than 300, LDL more than 190, or blood pressure more than 80 by 110, family history without other major risk factors, moderate CKD, EGFR 30 to 60, and diabetes, target organ damage with diabetes duration more than 10 or other additional risk factors. This is a high risk patient where the goal for LDL should be less than 70, and a very high risk person in which the goal has to be 55. There is established ASCVD, clinical or imaging, score is more than 10, family history of ASCVD or with another major risk factor, severe CKD, EGFR less than 30, diabetes, target organ damage, more than 3 major factors, or early onset type 1 diabetes with longer duration more than 20. These are very high risk patients, and the LDL goal has to be less than 55. This is ESC 2019 guidelines for dyslipidemia management. So statin therapy is recommended in all ACS patients. ESC 2019 recommendation, high risk ACS patients for dyslipidemia management. So this is class 1A indication in all ACS patients without any contraindication or definitive history of intolerance. It is recommended to initiate or continue higher dose of statin as early as possible, regardless of initial LDL levels. Lipid levels should be reevaluated 4 to 6 weeks after ACS to determine whether a reduction of at least 50% from the baseline and goal levels of less than 55 have been achieved. Safety issues need to be assessed at this time and the statin treatment dose adapted accordingly. This is class 2A, level C recommendation. And if the LDL goal is not achieved even after 4 to 6 weeks with maximum tolerated statin dose, combination with ezetimibe has to be recommended. This is again class 1B recommendation. So ezetimibe has to be added after 4 to 6 weeks if the target goal of LDL is not achieved, or the patient even after maximum tolerated dose of statin has been started. So does aggressive statin therapy reduce coronary atherosclerotic plaque lipid content? Results from reduction in yellow plaque by aggressive lipid lowering therapy. This is a yellow trial. This was a Journal of American College of Cardiology, JACC 2013. The yellow trial. So 2-3 vessel coronary artery disease. Total subjects were 87. After stenting the target vessel, the non-target lesions were underwent FFR. So FFR is fractional flow reserve. So out of the 87, 43 were standard and 43 were aggressive, in which continuous statin the patient was taking dual antiplatelet therapy for 1 year, and in aggressive arm, rosuvastatin 40 mg daily was started with dual antiplatelet therapy for 1 year. Follow-up cath after 6 to 8 weeks was done, where FFR, intravenous ultrasound, and near infrared spectroscopy was done. If the FFR was less than equal to 8, lesions stented and imaging repeated, and the FFR was more than 8, the patient was treated medically. So imaging data analyzed by CRF core lab, data analysis from primary outcome analyzed by MHC independent core lab. So the percentage change in lipid core burden index in post ACS patients, results from reduction in yellow plaque by aggressive lipid lowering therapy, yellow trial. So the study demonstrated an independent association between fibrous cap thickening and improved cholesterol efflux capacity that may contribute to morphological changes, suggesting plaque stabilization and regression among patients taking intensive statin therapy within 6 weeks of therapy. So rosuvastatin showed higher LDL reduction compared to atorvastatin. This is lunar primary endpoint, in which rosuvastatin 20, 40, and 80 were compared. You can see rosuvastatin 40 with average reduction of LDL from the baseline was almost 46.8%, while with 20% rosuvastatin was 42%. There was no additional advantages of increasing the dose to 80 milligram of rosuvastatin. Example of regression of atherosclerosis with rosuvastatin in asteroid measured by intravascular ultrasound. Asteroid external elastic membrane was measured. So rosuvastatin 40 milligram showed plaque regression. Asteroid trial, a study to evaluate the effect of rosuvastatin on intravascular ultrasound derived coronary atheroma burden. 78% showed plaque regression with rosuvastatin 40 milligrams per day. So does the risk end here? Need to continue therapy? So both non-culprit lesion and culprit lesion have a similar risk for recurrent events for the next 3 years. So don't forget the non-culprit lesion is what I want to tell you. The prospective study of natural history of atherosclerosis over 3 years in patients with ACS who underwent ACI. Cumulative rate of major adverse cardiovascular events of culprit lesions were 12.9 and non-culprit was 11.6. So it was almost comparable. So non-culprit lesions cannot be forgotten and it has to be treated aggressively. So regression, early disease, rosuvastatin and placebo, change in maximal carotid intima thickening of 12 segments. In advanced disease, change in percentage of atheroma volume, almost 7.79 reduction with p-value less than 0.001, and change in most disease 10 millimeter subset or almost 5.6 millimeters with rosuvastatin. So this is another patient. This is a 42-year-old male corporate worker, family history of diabetes, both parents, past history, diabetes, hypertension, smoker, medical history, diagnosed with type 2 diabetes 2 years back on metformin plus DAPA, glyphosine. His blood pressure is 150/90, pulse rate is 92. His HbA1c is 7.1. His current lipid profile shows LDL of 139, HDL of 42. His triglycerides as 160. 6 months before, his lipid profile had almost similar numbers. LDL was 143, HDL was 41, and triglyceride was 172. Currently, he is on lifestyle modification, no medications for dyslipidemia. So, such a patient, does he need any therapy for managing diabetes and dyslipidemia better? Lipid lowering therapy accounts for more than 70% of the CV risk reduction in diabetic patients. This is analysis of cardiovascular risk of patients with type 2 diabetes derived from Steno 2 study, calculated using UKPDS risk engine. So percentage of total calculated risk reduction in CVD events. Lipid has the maximum percentage when it comes to reducing the risk of CV risk as compared to HbA1c and systolic blood pressure. So the UKPDS risk engine is an epidemiological tool calculating the risk of cardiovascular events in patients with type 2 diabetes on the basis of age, fasting cholesterol, HDL, systolic blood pressure, glycemic control, smoking habits. Average risk factor profile of patients in the intensive therapy group at the baseline at the end of the study have been calculated, thus giving an opportunity to differentiate the cardiovascular risk reduction into each of these entered variables. So, of the 3 variables that the risk engine considers, lipid lowering has the maximum risk reduction with respect to CV risk. So we shall evaluate the patient for dyslipidemia management, need for statin in primary prevention. So rosuvastatin was found to be more effective in reducing LDL-HDL ratio and non-HDL cholesterol versus atorvastatin in 16 weeks in primary prevention patients. The Uranus study, patient aged more than 18, type 2 diabetes with LDL more than 127 were taken. Rosuvastatin 10 to 40 milligrams was compared with atorvastatin 10 to 80 milligrams. So you found all the parameters like LDL, HDL, triglyceride, LDL-HDL ratio, and non-HDL cholesterol. They all had better outcomes with rosuvastatin as compared to atorvastatin. Dose was titrated from week 4 to 16 in patients who did not reach the target of 100. Jupiter, that is justification for use of statin in primary prevention and intervention trial evaluating rosuvastatin. So the primary objective of this Jupiter trial was to investigate whether long-term treatment with rosuvastatin 20 milligram decreases the risk of first major cardiovascular events, compared with placebo in patients with low or normal LDL cholesterol, but an increased cardiovascular risk as identified by elevated CRP levels and inflammatory marker. Almost 17,802 patients were randomized. That's a huge number. Primary endpoint, time to first occurrence of major cardiovascular event, composite of cardiovascular death, stroke, MI, unstable angina, arterial revascularization. They were the primary endpoints. Secondary endpoint consists of total mortality, non-cardiovascular mortality, development of diabetes mellitus, venous thromboembolic events, bone fractures, discontinuation of study medications due to adverse events. Median age was 1.9 years. So rosuvastatin helped reduce LDL cholesterol by almost 50% in a year. Change in lipid parameters and HSCRP from baseline with rosuvastatin versus placebo. So this is Jupiter trial. Between the group difference from baseline at 12 months, LDL reduction was almost 50% at the end of 12 months. HDL rise was almost 4%. Triglyceride reduction was almost 17%, and HSCRP showed reduction of 37% in rosuvastatin group arm as compared to the placebo, the Jupiter trial. So rosuvastatin treatment reduced risk of other CV events as well. Change in lipid parameters and HSCRP from baseline with rosuvastatin versus placebo. There was 4% risk reduction of MI, stroke, revascularization, CV deaths. Almost 47% reduction in MI, stroke and CV deaths. There was 48% reduction in fatal and non-fatal strokes. Almost 54% reduction in fatal and non-fatal MI. Almost 45% CV events in CKD, and all-cause mortality in CKD was reduced by 44% with rosuvastatin. So what does the recent ESC and ADA guidelines recommend? With 50% reduction in LDL cholesterol, CV events reduced significantly. Achieved LDL levels, number needed to treat to prevent one event. LDL decision making could be based on net benefit as estimated by number needed to treat. So there was definite reduction of CV events in patients who were treated with rosuvastatin. Patients without dyslipidemia may have moderate or very high CV risk, ESC guidelines. So very high risk, we have already discussed that people with any of the following, that is documented atherosclerotic cardiovascular disease, either clinical or equivocal on imaging, documented ASCVD, previous acute coronary syndrome, MI, unstable angina, stable angina, coronary revascularization, PCI, CABG or other arterial revascularization procedures, stroke, TIA, peripheral arterial diseases, unequivocal documented ASCVD on imaging includes those findings that are known to be predictive of clinical events such as significant plaque or coronary on coronary angiography or CT scan. Diabetes with a target organ damage or at least 3 major risk factors, or early onset type 1 diabetes with duration more than 20 is again a very high risk candidate. Severe CKD, eGFR less than 30, a calculated score of more than 10 for 10 years risk for fatal CVD, and familial hypercholesterolemia with ASCVD or with other major risk factors. So in very high risk group, the target LDL should be less than 55. In high risk group, where the total cholesterol is more than 310, LDL is more than 190 or BP is more than 180, 110. Patients with family history with or without any major risk factors. Diabetes without target organ damage and diabetes duration more than 10 years. And moderate CKD where eGFR is 30 to 59 and calculated score is more than 5 and less than 10 for 10 years risk for fatal CVD. In this is a high risk patient where the LDL target should be less than 70. In moderate risk, the LDL target should be less than 100. These are patients with type 1 diabetes less than 35 years of age or type 2 less than 50 with duration of diabetes less than 10 without any other risk factors, and calculated score is more than 1 but less than 5 for 10 years risk of fatal CVD. And very low risk patients, this calculated risk is less than 1 for 10 years. The target LDL should be less than 116. So intensification of statin to be considered before combination. ESC 2019 guidelines for dyslipidemia management in diabetes. Treatment of dyslipidemia and diabetes in patients with type 2 diabetes at very high risk, and LDL cholesterol reduction of 50% from baseline and an LDL cholesterol goal of less than 55 as recommended. In patients with type 2 diabetes, an LDL reduction of 50% from baseline, an LDL goal of less than 70 is recommended. In statins are recommended in patients with type 1 diabetes who are at high risk or very high risk. Treatment of dyslipidemia in diabetes. Intensification of statin therapy should be considered before the introduction of combination therapy. If the goal is not reached, statin combination with ezetimibe should be considered. For patients with diabetes and age 40 to 75 without atherosclerotic cardiovascular disease, use moderate intensity statin therapy in addition to lifestyle modifications. In patients with diabetes and age 20 to 40 with additional atherosclerotic cardiovascular risk factors, it may be reasonable to initiate statin therapy in addition to lifestyle modification. And in patients with diabetes at higher risk, especially those with multiple atherosclerotic cardiovascular disease risk factors or age 50 to 70, it is reasonable to use high intensity statin therapy. So, what is about Crestor safety? Crestor is a hydrophilic statin with lower risk of some side effects. So, rosuvastatin, it's hydrophilic. Its metabolism is non-CYP 450 and limited to CYP 2C98. Clearance is hepatic and renal. Half-life is 20 hours, and effect on food and bioavailability is nil. As compared to the other statins that are available, atorvastatin, fluvastatin, lovastatin, pivastatin, they are all lipophilic, whereas pravastatin is again hydrophilic and simvastatin is lipophilic. Most have their hepatic metabolism, except for pravastatin, which is hepatic and renal metabolism. And half-life of all the other statins is less as compared to rosuvastatin, except for atorvastatin, which can have a half-life from 11 to 30 hours. And effect of food and bioavailability, atorvastatin, fluvastatin, and lovastatin all have decreased bioavailability with food, except for pivastatin and simvastatin. So, Crestor demonstrates a favorable benefit-risk profile across its dosage range, especially in muscle function, reduce LDL more effectively than other statin with no dose-dependent effects on muscle. Occurrence of so this is a flowchart where it shows Crestor having the least effect on the muscle. So, choosing the innovator, Crestor has the largest clinical program for efficacy to protection and saving lives. The original rosuvastatin Crestor has globally effective experience of clinical use. It is marketed in more than 100 countries. Over 739 clinical trials have been done. More than 2,482 related literatures. Almost more than 400 billion clinical prescriptions have been used of Crestor. The original research rosuvastatin brand has globally extensive experience of clinical use. Atorvastatin generic obtained from multiple sources worldwide contain a methylated impurity that reduces their HMG-CoA reductase inhibitory effect. So, this is a paper published by Richard Preston Mason. A methylated atorvastatin impurity was highly conserved in generic atorvastatin formulation from more than 30 manufacturers worldwide. This impurity was shown to have no inhibitory effect on HMG R enzyme activity, and the presence of this impurity is widely available version of generic atorvastatin may compromise global efforts towards the effective management. The Spanish registry data, real world study on outcomes with generic versus brand atorvastatin. So, this is the comparison. Cumulative probability of all-cause mortality with initial statin therapy during a 5-year follow-up period with previous cardiovascular events. You can see significant difference in generic and innovator statin. So, compared to innovator statin, the adjusted probability of all-cause death was significantly higher with generic, that is 62%, higher in risk, higher risk in patients with previous cardiovascular events, poorer treatment persistence and adherence in patients on generic statins, also because of intolerance, and patients receiving generic were more likely to unlikely to reach the target LDL goals. Thank you.
Thank you, Sumit. Thank you,
Yeah.
Sumit, for your elaboration on the management of dyslipidemia, especially the role of statin, rosuvastatin in primary and secondary prevention of cardiovascular diseases. There are two questions from, one is from Dr. Mohan Pathak, sir. Is the side effect of statin is colon cancer? Is it true? Is it true? Colon cancer and
Sorry, sir, I
what
did not get the
is,
question. Hello?
side effect of statin as a
Yeah.
colonic cancer. Colonic
So all of us, most of the people who are there, who attended, all my senior colleagues also, we use statin in and out every day, and it is a part of our prescription in almost most of the patients with diabetes, hypertension, or any other CV events. I have personally not seen any colon cancer with use of statin. Neither does the insert or the warning mentions any risk of colonic cancer with the use of rosuvastatin. Not that I'm aware of.
yes. There is actually no it's not a side effect of statin, and so everybody must be using statin right and left. So there is there is one another question from Dr. Samar Shah. What is the prevalence of genetic dyslipidemia in India, and how does it change the management of ischemic heart disease?
So it is quite prevalent, genetic dyslipidemia or familial dyslipidemia, as you call. I am not aware of the exact number, but it is quite prevalent. You see a lot of patients with familial dyslipidemia in the OPD. How does it change the management of ISD? So these patients with familial dyslipidemia, if they have a family history of any ASCVD event, definitely these patients needs to be on aggressive or a high intensity statin dose, as I mentioned in my slides as well, because then that patient is at again risk of any cardiovascular events or any stroke event. So they have to be managed aggressively, and the target LDL has to be achieved in such patients with intensive statin therapy.
So, thank you, Sumit sir. And there is final question from the Abhay Vaidya regarding, does statin reduce HDL levels?
Sir,
does statin HDL levels?
So statin does not reduce HDL levels. In fact, rosuvastatin has shown to marginally increase the HDL level by almost 4% in a study which I mentioned in my slides. So HDL reduction does not happen with rosuvastatin use. In fact, there is slight increase in HDL levels with rosuvastatin use.
Okay. Thank you, Sumit sir. Thank you for your it was very interactive session. And now I request Dr. Varyani sir and Dr. Virendra sir to felicitate Dr. Sumit Agarwal sir.
Thank you very much, Dr. Sumit Agrawal, for your excellent talk.
Yes, thank you,
Please
sir.
accept IMA Uparna as a token of appreciation.
Sumit, this is IMA financial diary for you.
Thank you so much, sir. I will definitely come and collect it from the IMA. Yeah.
Thank you very much.
Thank you, Sumit sir. So now we go to the next presentation. I think Dr. Somani sir, Dr. Abhay Somani sir is ready with his presentation.
Sachin sir, I'll be sharing the slides. Abhay sir has joined, so I'll be just sharing the slides.
Okay.
Yes, sir.
Deepen, you have made him co-host. Dr. Somani sir, you have made him co-host.
Yes.
Yes. Somani sir is. So after Dr. Sumit talk, it's regarding Dr. Somani sir. Dr. Abhay Somani is a cardiologist, interventional cardiologist, and pediatric cardiologist in city of Pune, with experience of more than 17 years in field of cardiology. Over the past 17 years, he has developed extensive experience in adult interventional cardiology, including cardiac catheterization, angiography, and complex angioplasty. He is a fellow of American College of Cardiology. He is actively involved in various academic and research programs, has given talks on diverse cardiac topics. He's director at Somani Cardiac Center, Kothurud, and he's head of department Ruby Hall, Wanuri. So to hear from Dr. Abhay Somani, meditated the high thrombotic risk in acute coronary syndrome patients.
Thank
So,
you,
Dr.
Sachin.
Abhay, over to you.
Yeah, thank you, Dr. Sachin. Virendra, we can start. So we are going to talk about the high thrombotic risk patient in acute coronary syndrome and how are we going to mitigate this risk. Next. So what are the challenges? There is high ischemic recurrence post-acute coronary syndrome. Next. Every 1 in 5 patients with acute coronary syndrome suffers another myocardial infarction, cardiovascular death or stroke within the first year. A third of recurrence occurring these events are fatal. Next. Next. So 1 in 5 patients who is a high thrombotic risk patient, and do we encounter high thrombotic risk patient? 1 in every patient. Next. High thrombotic risk patient, basically clinical. What are the clinical risk factors? And there are certain procedural risk factors for thrombotic risk. What are the high clinical risk factor? Type 2 diabetes, multivessel disease, more than 1 prior myocardial infarction less than 2 years of age, peripheral vascular disease, age more than 65 years, and chronic kidney disease. And what are the procedural risk factor? The procedural risk factor include 3 coronary vessel disease, more than 3 stents implanted, more than 3 lesion treated or the 3 vessel treated, bifurcation with more than 2 stents, total length of the stent more than 60 mm, CTO vessels, unprotected PCI, instant restenosis of the target lesion, and clinical risk factor in which there is a chance of high thrombotic risk. Next. Thrombotic risk assessment as per ESC 2020, the risk factors or the risk criteria, and moderate thrombotic risk and high thrombotic risk, and as we have discussed, the complex coronary lesion and a percutaneous procedure. Just now we have talked about more than 3 stents. Treated, critical localization, left vein, and the last patent vessel. High risk procedure including bifurcation with more than 2 stents or chronic total occlusion and history of stent thrombosis with antiplatelet. And these high thrombotic risk patient is complex and percutaneous procedure, and or at least one of the patient that is either diabetic, recurrent myocardial infarction, coronary artery disease, peripheral vascular disease, premature, that is less than 45 years of age, or accelerated new lesion within the 2 years of the index procedure, concomitant systemic inflammatory disease, and CKD with eGFR between 15 to 59. Moderate thrombotic risk. Lost the slides. Virendra? Hello?
Just a minute, sir. Yeah, I'm connecting.
Virendra Somani Saran's voice is not audible.
अबे सर
Sachin?
आवाज नहीं है. Hello.
Abhay, yeah.
Virendra cannot see the slides. What?
Virendra slide.
हाँ सर सचिन
Virendra-
सर कर दो शेयर. हाँ अबे सही है. आई एम शेयरिंग इट.
Okay. Go to the previous slide, Virendra. Previous. Yeah. So sorry for the. I think there's some technical issue at Virendra's. Moderate traumatic risk would include patient with one of the following, that is diabetes, recurrent myocardial infarction, peripheral vascular disease, and chronic disease. Next. Is there any technical issue?
Abhay, I think you stopped sharing your videos, and so the network will be stable and better connectivity will be there.
Okay. Now, it's okay now. So we have.
Yeah, that's okay. That's okay.
Let's see. Okay. Ischemic risk factor to watch out from the preclude trial. So these are the risk factors what we have already discussed: elderly patient more than 65 years, multi-vessel disease, chronic kidney disease, diabetic, prior myocardial infarction, and prior bleeding. All of these are high risk patients for recurrent myocardial infarction or high thrombotic risk. Next. So myocardial infarction patients with a clinical ischemic are more likely to have recurrent events. Next. The pattern of non-adherence to antiplatelet regime in the stented patient, thrombotic risk score, what they say is basically when the high risk score, that is risk score is more than 5, the mortality risk in high risk patient is 2.3 times higher than that in the low risk patient. And they have given points for each of these patients, whether the patient is diabetic, non-diabetic, insulin dependent, or non-insulin dependent. Acute coronary syndrome, whether it is coronary syndrome, and yes, and if yes, then troponin positive, troponin negative. Then current stenting, yes or no. Creatinine clearance, depending on the creatinine clearance, if it is eGFR is less than 60 per ml or not more than that 60 ml. Prior PCI, yes or no, and prior CBG, yes or no. So on all these, they have been categorized these patients on 3 categories: low risk, intermediate risk, and high risk. Low risk is who score is 0 to 1, intermediate risk is score 3 to 4, high risk is more than 5. Next.
15 days. 21 days.
Next. Yeah, so 53% of the patients who have 2 or more concomitant high risk factor, which is seen in the Swedish registry, and they found out that the mortality was 53.8%. we do this factor with each of them added to this factor, there is a marked increase in the incidence of cardiovascular mortality, myocardial infarction, and stroke. So more the risk factors, more would be the mortality, and more is the high thrombotic risk. Next. 85% of the ACS patient had 3 or more clinical and angiographic high risk features, which was seen in Twilight trial. Next.
Oh.
Declared XR 90 and 120. In addition to declared XR 60, declared XR. The total 90 and 120 medical patients
Next.
Within
the
1.5 tablet and 2 tablets for medical patients are there. 90 and 120.
How long and high is the ischemic risk in the high thrombotic risk patient? Let us see now. We have seen what are the risk factors for high thrombosis, and now how long does this risk prevent? Next. Next. 46% of the high risk MACE in high thrombotic risk patient at 1 year. So a retrospective study of cohort study, which included 186,000 patients with acute myocardial infarction from 2009 to 2010 in all the Italian hospital was studied and who were alive at 30 days after the index event. And high thrombotic risk was defined as at least one of the following in the following 5 years after acute myocardial infarction: prior myocardial infarction, ischemic stroke or other vascular disease, type 2 diabetes, and renal failure. The overall 5-year risk of MACE was higher in the patient with high thrombotic risk in those without high thrombotic risk in both the survivors at 30 days and at 1 year, with the incidence of 1.46. The risk of MACE events after 1 year of myocardial infarction over 5 years in the patient with high thrombotic risk. Next. So complex PCI are at 72% higher MACE rates over the period of 2.5 years. So the lower the patient subgroup is non-complex and the upper subgroup is a complex PCI, where we can see the incidence rate is 7.9% as against 4.6% in the non-complex PCI group. Next. So patient with recurrent myocardial infarction doubled the risk of 5 years all-cause mortality, which was seen in this OASIS registry. Next. Coronary artery disease patient with multivessel disease or diabetes are at sustained or higher risk up to 7 years, which was seen in IMPROVE IT trial. Next. Patient with multivessel disease. Next. I think there is a lag. High thrombotic risk patient at 2.3 times higher risk of MACE, which increases up to 5 years steadily. Next. Nearly 1 in 2 high thrombotic risk patient will experience a recurrent event within 5 years of the index event. Acute management of high thrombotic risk patient with appropriate antiplatelet agents. Oral antiplatelets. Next. So we all know that there are 3 oral antiplatelets. Next. Clopidogrel, prasugrel, and ticagrelor. Clopidogrel, prasugrel, and ticagrelor. Previous slide. So cardiovascular death, myocardial infarction, and all-cause death was seen highest with clopidogrel as compared to ticagrelor. So we can see that 7% cardiovascular death is seen in clopidogrel subgroup. Prasugrel, it was 11%, and ticagrelor, it is 21%. That is significant reduction was seen. Myocardial infarction, again, there was a 16% reduction in acute myocardial infarction in ticagrelor as compared to prasugrel, which is 24%, and clopidogrel 30%. All-cause death is seen significantly reduced, 22% reduction in ticagrelor group as compared to -17% in clopidogrel. Next. So 0 stent thrombosis was observed in the patient with ticagrelor, while in clopidogrel there was 9% stent thrombosis as compared to ticagrelor. So there is 100% relative risk reduction in the stent thrombosis with ticagrelor and 89% relative risk reduction in the MACE with ticagrelor as compared to the clopidogrel was seen. Next. In the plateau trial, benefits as early as 30 days were seen, and the benefit did continue and extended up to 1 year. And there was a difference. You can see the divergence of the curves between the clopidogrel and ticagrelor over the period of time, and over almost like 30 months, 30 days, and then later we can see that 330 days. That is, the separation of curve is seen as early as within few days. And the separation of the curve gets maintained over 1 year period. Next. %21 relative risk reduction of cardiovascular death and 16% relative risk reduction of myocardial infarction was seen with ticagrelor. Is the only P2Y212 demonstrate the mortality benefit at 1 year. At clopidogrel, there was no mortality benefit have been shown. Next. But ischemic risk in high thrombotic risk patient extends well beyond 1 year. Next. So ticagrelor plus aspirin showed a 16% relative risk reduction in MACE as compared to aspirin alone at 48 months from index myocardial infarction, which was seen in the Pegasus TB54 trial. So this Pegasus TB54 trial was conducted over a period of 4 years. And we see that ticagrelor and aspirin was better as compared to aspirin alone. Next. From these also, we have seen that the major bleeding was higher than placebo, but fatal bleeding, that is intracerebral bleeding, was similar between ticagrelor 60 mg and placebo. So this Pegasus trial was basically a trial which was designed for the ticagrelor use beyond 1 year, and it was used up to 4 years with a reduction in the dose. 60 mg was used as twice daily in Pegasus trial. Next. So ischemic reduction clearly outweighs the risk of the major bleeding when ticagrelor 60 mg is initiated within the 2 years of myocardial reduction, and it is continued. Next. Balancing the ischemic versus bleeding risk in high or traumatic risk patient. So how we are going to balance, we'll see in a couple of slides. Next. So carefully assess the bleeding risk versus the ischemic risk. This assessment is a critical component of evidence-based therapy. Associated risks include the bleeding are sometimes overestimated. And these patients who are more likely to benefit do not receive the optimal oral antiplatelet agents or the optimal treatment. Objective risk assessment may help reduce the adverse events then result from undertreatment of the high-risk patient. So we have to fully engage the patient in decision making. Next. So assessing bleeding risk versus ischemic risk can be challenged in acute coronary syndrome patient because there is a significant group in which there is an overlap. Patients who are at high risk of ischemic event also are at high risk of bleeding. For example, the elderly female patient, chronic renal dysfunction and diabetes. All these 4 categories are at high risk of ischemic events as well as high risk of bleeding. Apart from that, whether the high risk, which are the patient in whom the bleeding risk is high, patient on dual antiplatelet, bleeding diathesis, prior bleeding events, liver dysfunction, anemia, thrombocytopenia, chronic anticoagulation, and second generation drug-eluting stents. And where is the high ischemic events? We have already seen that recurrent events, despite dual antiplatelet agent, prime myocardial infarction, complex angioplasty, multivessel plasties, multiple of bifurcation lesion, peripheral vascular disease, and first generation drug-eluting stents. Next. Bonaka identified two predictors of major bleeding. In the Pegasus TV54 trial, were able to identify two independent risk factors for major bleeding. And what was there? History of spontaneous bleeding requiring hospitalization and the low baseline hemoglobin, that is anemia. Patient with either of these predictors of bleeding were defined as high bleeding risk, and the other patient were defined in the low bleeding risk category. Next. So a practical method to look at the bleeding and ischemic events together, more than two risk factors for the patient. What is the selection algorithm? Let us see. Next. So in this Pegasus TV54 trial, efficacy and the safety. And what was the algorithm? Basically, there is a step 1 and step 2 in this algorithm. I think it is too small. Step 1 is basically the prior hospitalization for bleeding and low hemoglobin. This is the step 1. These are the high risk patient. And the step 2, the other patients in whom diabetes is there, peripheral arterial disease, chronic kidney disease, prior myocardial infarction, and IMA within 2 years of this patient. So Pegasus TV54 trial, high bleeding risk, almost 19% of the patients are there, and low bleeding risk, almost 80% of the patients would be fall in low bleeding risk. If the ischemic event is more than 25, 0 to 1 ischemic risk factor, then 27% is the recurrent thrombotic events. And more than 2 risk factors of the high ischemic risk factor, the thrombotic event or the high thrombotic incidence can go up to 59%. Next. Within the next. So in the step 1, when we exclude 19% of the patient who are at high risk of bleeding, what is the basically what happens is patient with any of these predictors, that is a high bleeding risk, have been excluded, and the other remain as 81%, which are included in the low bleeding risk. Next. Next. So low bleeding subgroup patient is going to receive ticagrelor 60 mg twice daily beyond 1 day. And high risk of bleeding are not going to receive ticagrelor after 1 year. Next. So this was step 2 in which we have predicted count the number of the risk factors among the low bleeding risk in the patient with 2 or more risk factors. Ticagrelor provides significant benefit. So we have already seen the risk factors, that is a diabetic patient, acute myocardial infarction within less than 2 years, recurrent events, multivessel disease, left main disease, peripheral vascular disease, chronic kidney disease, and multiple prior myocardial infarction. So if any patient is having more than 2 risk factors, then this guy is going to receive ticagrelor 60 mg twice daily. Beyond 1 year period, generally up to 3 years, we are recommending to give ticagrelor in high risk patient. And we have seen that there is a decrease in the bleeding risk. Next. Next slide. I cannot see the slide. Yes. In low bleeding risk patients, that is 21% relative risk reduction of MACE with more than 2 risk factors. Next. So significant mortality benefit was seen in the low risk patient who have more than 2 risk factors. there is 34% relative risk reduction in cardiovascular death for marker infarction, cardiovascular death in more than 2 risk factors, and 24% relative risk reduction for all-cause death in more than 2 risk factor patients. Next. So patient selection algorithm summary, marker infarction with 2 risk factors get the greatest benefit from ticagrelor 60 mg twice daily. In short, it is going to decrease by relative risk reduction by 34% in cardiovascular mortality and 21% relative risk reduction or cardiovascular death marker infarction is seen with 60 mg twice daily. Next. So 4 years cover of ticagrelor for high-risk patient summary. This is what it is summarized. First 12 months, 90 mg twice daily. There would be 21% decrease in cardiovascular death relative risk factors and 34% relative risk reduction beyond 1 year to 4 years in patients who are with low risk of bleeding, very clearly low bleeding risk and who have more than 2 risk factors. Next. I think we'll stop at this point. We are not going to go for the choices of the brand among the ticagrelor makes a difference. Yes, we all know that we have been sticking to the original ticagrelor, in which we have seen that the bioequivalence is not equivalent to therapeutic equivalence. So every time, because some molecules are highly complex, so making the generic molecule is can have its own impurities, and the therapeutic window is wide because the acceptance is from 0.75 to 1.25% of the impurities have been accepted. So with more than 10 years of experience with the innovator, I think we would all like to stick to ticagrelor brand Brilinta as the agent for preferred agent for ticagrelor and dual antiplatelet. Thank you.
Thank you, Abhay. Thank you, Abhay, for your nice talk. Dr. Abhay has discussed about the ticagrelor, its role in reduction in stent thrombosis, as well as for 1 year, as well as beyond 3 years, up to 4 years, how the benefit of ticagrelor is there in patients after post-angioplasty, and also the role of original ticagrelor Brilinta, which has bioequivalence study has been done, and how the therapeutic benefit of original molecule, innovator molecule Brilinta scores over the other brands. So thank you, Dr. Abhay. And now I request Dr. Varyani sir and Dr. Virendra sir to felicitate Dr. Abhay Somani sir.
Thank you, Dr. Abhay Somani sir, for your excellent talk.
Thank you,
Please
sir.
accept IMA as a token of appreciation.
Thank you, sir. Thank you.
And sir, here is the IMA diary.
Thank you, sir.
Thank you so much.
Thank you.
Thank you, Abhay. Thank you.
Sachin, thank you. Bye.
Yeah. So moving to the last talk of today's webinar. So Dr. I think Raju Sethi sir has joined. Yes, he's there. So he'll be talking on the how to lower the risk of stent thrombosis on the case-based studies, and to hear from Dr. Raju Sethi sir, he's senior interventional cardiologist in CT of Pune. Vast experience in coronary angiography, angioplasty, complex angioplasties, device closure, pacemaker implantations. He's also fellow of American College of Cardiology and fellow of European Society of Cardiology. He has experience of more than 25 years in field of cardiology. He's attached to Birla Hospital, Jupiter Hospital, and many hospitals in PCMC area. And to hear from Dr. Raju Sethi sir, lowering the risk of stent thrombosis case studies. Over to Raju Sethi sir.
Yeah, so thank you very much, Sachin, for the kind introduction. Am I audible?
Yes, sir, you are quite audible. And
Yeah,
just
are you
make
able
your
to see?
slideshow, sir. Request to do it's a slideshow.
Yeah, I will try to share again.
Yes, sir. Now slides are visible in presentation mode.
No? Yeah, let me just, okay. So now you're able to see the slides in presentation mode.
Yes, yes. Slides are quite visible in presentation mode, and they are also moving
Good.
slides. So,
So
no
good
issue,
evening,
sir. So
friends.
you can start your
Yeah.
talk, sir.
So good evening, friends, and I would like to thank IMA for giving me this opportunity. And I'll be speaking on the role of dual antiplatelet therapy in patients with acute coronary syndrome, especially in patients post-angioplasty. So we will go through a case, and this case will teach us as to how we should treat patients with acute coronary syndrome, especially after angioplasty with dual antiplatelet therapy, and what we should not be doing. So here's a 56-year-old male. He's a diabetic and he's a smoker. And he has suffered with acute chest pain. His ECG done at the time of pain showed ST elevation in leads V1 to V3, which is suggestive of anterior wall mitral infarction. And as is the protocol nowadays, whenever you have patients with ST elevation mitral infarction, we have to open the artery. And how do we open the artery? We open it by either doing angioplasty directly, called as PAMI or primary angioplasty, or we thrombolize the patient, give thrombolytic drugs like Elexim or streptokinase or tenecteplase, and after 24 hours, we do the angiography and see the block. So in this patient, he showed ST elevation mitral infarction in the anterior leads, and he was taken for primary angioplasty. That he was taken directly to the cath lab where angiography was done, and angiography, as expected, showed the LAD, that is the left anterior descending artery, was completely blocked. Now, what is the protocol as far as antiplatelet drugs is concerned in these patients? Now, the drug that we all give, and I'm sure whenever the patient comes to a hospital, is usually gone through a general practitioner or a physician, and they load these patients with aspirin and clopidogrel, which is the right practice. And they give statins also, either atorvastatin 40 milligram or rosuvastatin 20 or 40 milligram. And then usually the patient comes to the hospital. But when we take up the patient for primary angioplasty, we see to it that the patient receives the new antiplatelet agents, because these, as we will be going through the slides, have been found to be much superior to clopidogrel in preventing stent thrombosis. So similarly, this patient received aspirin and he received ticagrelor. And ticagrelor, whenever we load ticagrelor, we give 180 milligrams of ticagrelor. Remember, ticagrelor is available as 90 and 60 milligram tablets. In the acute setting, we always give 90 milligrams. So 90 milligram twice daily was loaded. And he then underwent angioplasty, where 2 drug-eluting stents were inserted in the LAD, and he was discharged. And on discharge, they all received aspirin, which is for life, and ticagrelor 90 milligram twice daily. Now, if you look at the dose of aspirin, the dose of aspirin is 75 milligrams. Now, this is important because if you increase the dose from 75 to 150 milligram in patients along with ticagrelor, you will reduce the effectivity of ticagrelor. And this has been shown in trials, especially coming from North America. So you must always remember that whenever you are giving aspirin along with ticagrelor, the dose of aspirin should be 75 milligram once daily and 90 milligram twice daily of ticagrelor. Now, what are the guidelines? That once the patient undergoes an angioplasty, or if he is admitted with an acute coronary syndrome, he should receive this combination of aspirin and ticagrelor for at least 1 year. Remember, at least 1 year. And this is what this patient did not receive. He went after his angioplasty, went to the village, and then after 3 months, for some reason, the ticagrelor was stopped and he was switched over from ticagrelor to clopidogrel. Now, there may be a genuine reason to switch over to clopidogrel, but when you switch over to clopidogrel, there is a protocol that you need to load the patient and then switch over to clopidogrel, which was not done, and he was directly given a maintenance dose of clopidogrel once daily, along with the aspirin. And 8 days later, when he was on aspirin and clopidogrel, he again developed chest pain and he developed frank ST elevation in the anterior leads, something what we call as reinfarction or stent thrombosis. And this is a ECG which shows an RBBB and ST elevation in the anterior leads. And this is the angiogram. When we took him up, you can see that the LAD at the level of the stent is completely blocked. And then he underwent what we call as rescue angioplasty with the help of wire, balloons, suction catheters, and so on. And we got a good result. And now we ensured, and we always tell our patients that whenever we do a good job in the cath lab and discharge you, you must see to it that you continue with ticagrelor at least for 1 year. And there should be absolute genuine reason for stopping ticagrelor. And if at all you need to switch over from ticagrelor to clopidogrel, there is a protocol in which you need to load clopidogrel 300 milligrams and then give clopidogrel so that you reduce the incidence of stent thrombosis. Now, coming to dual antiplatelet therapy, what is dual antiplatelet therapy? It is a combination of aspirin and a P2Y12 inhibitor. Because we knew that aspirin alone is not enough, because platelet aggregation occurs by different mechanisms, and we need to block all the mechanisms to prevent thrombosis. So aspirin is usually combined with the P2Y12 inhibitor. And whether this is the patient is undergoing angioplasty or patient is undergoing medical therapy, it becomes very important that they receive these two drugs at least for 1 year after acute coronary syndrome. Now, it becomes very important that whenever we take a decision in prescribing DAPT, there are a number of challenges. First, we need to select the right P2Y12 inhibitor. So aspirin is going to be there. Now, with aspirin, which other P2Y12 inhibitor will you give? It depends upon, so you have to choose the right P2Y12. And second important thing is you have to choose the duration of DAPT. That the duration of DAPT should be at least 1 year, and we have to look at the bleeding and ischemic complications and then decide on the dose, on the duration of therapy. Now, what are the P2Y12 inhibitors available with us? We have 3 P2Y12 inhibitors available with us, which we combine with aspirin. One is clopidogrel, the other is prasugrel, and the third is ticagrelor. Now, these 3 drugs, they differ with each other. What is the difference? Clopidogrel and prasugrel are prodrugs. So clopidogrel takes some time to act. If you give 600 milligram dose of clopidogrel, it is going to take at least 2 to 3 hours for the platelets to be inhibited. That's why cardiologists don't like it during angioplasty. Because when you are giving it during angioplasty, you want the action to occur instantaneously, and that can be achieved with prasugrel and ticagrelor, where the action can start within half an hour. So that is the advantage of these new drugs. Also, clopidogrel is a weak antiplatelet agent. So the platelet inhibition is not complete. It is around 70%. So you need better drugs, more powerful drugs. So the more powerful drugs are prasugrel and ticagrelor. And thirdly, there are around 15 to 40% of patients who are clopidogrel resistant. Because it is a prodrug, it goes to the liver. There are multiple enzymes which act on it, and there is resistance. So it is very difficult to make out who is clopidogrel resistant and who is not clopidogrel resistant clinically. I mean, there are laboratory tests, but we don't do laboratory tests in clinical practice. It is not practical. So when a patient comes, we don't know whether he is a clopidogrel resistant or not. So it becomes very difficult. And we have seen in the past that whenever we have done angioplasty and put the patient on clopidogrel and then stent thrombosis after doing a good job, and we find no other reason, that it is probably clopidogrel resistant. So now we have switched over from clopidogrel to these 2 new drugs, prasugrel and ticagrelor. But remember, whenever we give antiplatelet therapy, we need to balance the ischemic and bleeding risk so that the bleeding risk is low. And if you go through all the guidelines, wherever you choose, American, British, European, Indian guidelines in patients with acute coronary syndrome, whenever the patient is admitted with ACS, whether it is unstable angina, whether it is ST elevation myocardial infarction, the P2 vital inhibitor of choice is either ticagrelor or prasugrel, especially if the patient has to undergo angioplasty. So it goes without saying, nowadays we don't use clopidogrel in cath lab. We only choose either ticagrelor or prasugrel, and we'll be going through both these drugs, out of which of these are better. So these are the guidelines which say that in patients who are treated with DAPT, remember the dose of aspirin has to be low. It cannot be 150 milligram. It has to be 75 milligrams. Also, in patients who are undergoing stenting, we should not be using clopidogrel. We should be either using ticagrelor or prasugrel. And if you look, you have to see the duration. The duration has to be 12 months, because if you stop a P2 vital inhibitor earlier than 12 months, you will increase the risk of stent thrombosis. Why preventing stent thrombosis is a priority? Because it is a nightmare. You ask the cardiologist that if the patient comes to you with stent thrombosis, it carries very high degree of morbidity and mortality. As you can see, the mortality can be at least 4 times higher. So we need to prevent stent thrombosis. Now, stent thrombosis can be of multiple reasons. There can be for stent thrombosis, but if you see overall, and you must have heard in clinical practice also and seen in your clinical practice, that the overall incidence of stent thrombosis has reduced markedly all over the world. Even nowadays, we don't hear that these stents are thrombosing. Now, what is the reason? A, we are using very good stents. So the third generation or the recent generation of stents are excellent. The risk of stent thrombosis is much less with these stents. Secondly, we have better drugs. So we have better drugs like prasugrel and ticagrelor, which inhibit platelets much more than clopidogrel. So they are much superior to clopidogrel. And hence, the incidence of stent thrombosis is much better. And also, the cardiologists are now much better tuned to do angioplasty, because nowadays we use imaging techniques like intravascular ultrasound or OCTs. So we deploy our stents better. So the risk of thrombosis overall has gone much low in clinical practice as compared to what it was earlier. But then if a patient thrombosis, we need to have a look at the patient factors like clopidogrel, now if he's on clopidogrel, if he has stopped DAPT earlier, if there is diabetes and so on, which increases the risk of thrombosis. Procedural factors, as I said, the cardiologist knows what he has done, why whether there has been stent under expansion or some edge dissection, some lesion factors like bifurcation stents or calcified lesions can give rise to stent thrombosis. And if you are using multiple stents, the risk of thrombosis is higher. So why this patient thrombosed? I think the major reason was that he was switched over. The ticagrelor was stopped earlier, and he was switched over to maintenance dose of clopidogrel without giving a loading dose. And for all we know, he may be clopidogrel resistant. So we should try avoiding this. That's why we say in clinical practice, unless you have a very valid reason, you must try to see that at least 6 months. We say at least 6 months because now we have seen in our clinical studies and in our clinical practice that with ticagrelor and prasugrel, and especially with the new type of drugs, new type of stents that we use, up to 6 months, at least you should give, if it is possible, give it for 12 months post-stenting. You must continue with dual antiplatelet agents. So, as I said earlier, nearly 15 to 40% of patients are clopidogrel resistant. Very difficult to make out in clinical practice. There are laboratory tests which we don't do in clinical practice because they are not available in most of the places and they are very expensive. Now, if you understand why stent thrombosis occurs or why platelet inhibition with clopidogrel is inadequate as compared to these prasugrel and ticagrelor, you can see that the immature platelets overall play a very important role in thrombosis overall, because they have a greater number of dense granules and they are more thrombogenic. And these are the new platelets which are released. Now, when you give drugs like clopidogrel, it causes an irreversible inhibition of the platelets. So the platelet for its duration of life is inhibited, and to have a further action of clopidogrel, you will have to probably give a BD dose And we know that when we increase the dose of clopidogrel from OD to BD dose in clopidogrel resistant patient, it does not help. So that's why you have drugs like ticagrelor, because of their reversible inhibition of the platelets, and because of twice daily dosing of ticagrelor, it has been found to be much more beneficial than either clopidogrel or prasugrel in inhibiting the immature or the younger platelets. So that is the advantage. If you see on the right-hand side, clopidogrel and prasugrel, because they are given once daily, they may not be able to inhibit platelets much more as compared to ticagrelor. So a BD dose, and you require reversible inhibition, where I think ticagrelor scores over these agents in patients with acute coronary syndrome. So if you see ticagrelor, clopidogrel, and prasugrel, the three drugs which are available to us, now ticagrelor causes reversible inhibition. So what is the advantage of reversible inhibition? Is that you can stop early. If for some reason the patient has to undergo surgery, some surgery, while he is on ticagrelor, you can stop it for 3 to 5 days and take the patient up for urgent surgery. Whereas prasugrel and clopidogrel cause irreversible inhibition, so the action remains for 5 to 7 days. That's why if the patient has to go for CABG or if the patient has to go for some other surgery, you have to stop these drugs for at least 5 days with clopidogrel and 7 days with prasugrel. So that can be an issue. But if you see overall, prasugrel and ticagrelor are much more potent in inhibiting platelets. In fact, the bleeding is much more seen with prasugrel as compared to ticagrelor. Now, if you compare these three drugs, you can see as far as the results are concerned, on the left-hand side, clopidogrel, no significant reduction in cardiovascular mortality, no significant reduction in MI, no significant reduction in death. But if you see on the right-hand side, both prasugrel and ticagrelor are very potent, cause significant reduction in MI. But the problem with prasugrel is that it causes bleeding. Bleeding risk is higher. And it cannot be given in the ICUs. It has to be given in the cath lab. So it is a cath lab drug. And also it cannot be given to patients who are medically managed. And it cannot be continued beyond 1 year because the bleeding risk is high. And there are 3 subset of patients who have been identified with prasugrel, in which you should be very careful. And these we call as the relative or absolute contraindications to the use of prasugrel. Which are these 3 situations? 1, if the age is more than 75 years, or B, if the weight is less than 60 kgs, or third, if the patient has history of TIA or stroke in the past. So these 3 situations, avoid prasugrel. So in these 3 situations, we give ticagrelor. Sometimes it becomes very difficult when a patient comes to the casualty and in the middle of the night to decide whether which of these 2 drugs are to be given. So I think it overall, ticagrelor all over the world, and especially in our ICUs in Pune city, we usually prefer ticagrelor in patients with acute coronary syndrome, especially those who are undergoing angioplasty. They are to be preferred. Now, Dr. Somani discussed about giving DAPT for a longer duration of time. Well, the guidelines are very clear. We need to give these drugs for at least 1 year. But 1 year may not be sufficient in some patients. In some patients, I'm not comfortable in stopping ticagrelor at the end of 1 year. Which are these patients? These are patients in whom I have put in multiple stents. I'm not comfortable in stopping ticagrelor after 1 year. I'm not comfortable in stopping patients in ticagrelor in patients after 1 year if he is a diabetic, if he has peripheral arterial disease, if he has long stents, multiple stents. I want to make sure that my patient remains safe, my patient remains free of stent thrombosis for as long as possible. So I normally continue them for 3 years. And that is what data has shown us. The Pegasus trial, which was mentioned earlier, they have shown that ticagrelor, when it is given for 3 years, it reduces the coronary events. But just remember, In the acute setting, we need to give ticagrelor 90 milligram twice daily. But after 1 year, we need to reduce the dose of ticagrelor from 90 to 60, because Pegasus trial showed us that 60 milligram of the drug is as good as 90 milligram after 1 year, and bleeding is less. So this is the protocol, that if you have patient up to 1 year, you give aspirin 75 milligrams along with ticagrelor 90 milligram twice daily. After 1 year, you give aspirin 75 milligram and ticagrelor 60 milligram. How long will you give? Give it for 3 years, because that is the data that we have with the Pegasus trial. When they gave it for 3 years, there was a reduction in the overall mortality which was seen. And if you can see the stent thrombosis overall, much lower when ticagrelor is given than when clopidogrel is given. As you can see in this, the Plato overall study, 21% risk reduction in with ticagrelor as compared to clopidogrel, and more so in the invasive arm. So for stents, I mean, there is no doubt, no cardiologist would use clopidogrel nowadays post stenting. You know, all of them are either on ticagrelor or prasugrel, and ticagrelor has been found to reduce relative risk reduction of within 30 days of 40% and 52% respectively. And multiple trials have shown that the incidence of stent thrombosis with ticagrelor is much lower than with clopidogrel. So we don't use clopidogrel nowadays during angioplasty, especially if the patient has acute coronary syndrome. Certain situations, like if a patient has chronic stable angina, you may use clopidogrel, but then even in that situation, if the patient is requiring more than one stent or stent in situations which are important, such as left main, proximal LAD or OMs, or if the patient has diabetes, a high ischemic risk and low bleeding risk, I will never use clopidogrel. It is better to go for a much more superior molecule. So Pegasus trial showed us that you can continue it for 1 year. Now, Dr. Somani discussed on the dose, on how you choose which patient should receive DAPT beyond 1 year. No, usually, if the patient has tolerated DAPT for 1 year, he will tolerate it beyond 1 year also. You know, because if he has to develop bleeding, he would have developed it earlier. So usually they tolerate it, and you're trying to reduce the dose of from 90 to 60. So he's going to tolerate it definitely. But then always when a patient is on DAPT, you need to balance the ischemic and bleeding risk. So you need to assess whether the bleeding risk is high. If the bleeding risk is high, if your ischemic risk is less, stop ticagrelor after 1 year. Just continue with aspirin. But if your bleeding risk is low and if your ischemic risk is high, you must continue with ticagrelor 60 milligram twice daily, especially patients who have diabetes, especially with multivessel disease, prior MIs, renal impairment, and so on, where the risk of stent thrombosis is high. Now, he has already discussed about the ticagrelor brands. We all know in our clinical practice across, whether it is antiplatelets, whether it is antacids or so on, whether it is antibiotics, always the innovator brand is better because it has been tested in clinical trials, and there have been, I mean, the generic brand can have its own limitations, and this has been shown in clinical studies also. Like, for instance, in this study from Mount Sinai, where they did angioplasty in patients with acute coronary syndrome and gave them clopidogrel, they found a nearly 3-fold high risk of stent thrombosis. This was earlier. So nowadays, nobody will do this trial because nobody wants to give stent thrombosis, and you have better drugs. So it goes without saying that it is always better to have innovator brand and as compared to the generic ticagrelors, because we have a lot of evidence. We have evidence from randomized controlled trials, from real world registries, and so on, where it has been found to be superior. So I will stop here by summarizing that ticagrelor is the only P2Y12 inhibitor which has been shown to reduce cardiovascular mortality significantly. And it is always better to use the innovator brand, but we need to have a tailored approach. we need to tailor our approach of antiplatelet agents when advising the optimal antiplatelet therapy by looking at the ischemic and bleeding risk. If your ischemic risk is high, continue ticagrelor beyond 1 year to up to 3 years. The dose beyond 1 year is 60 milligrams twice daily and not 90 milligrams. But remember that you need to give ticagrelor 90 milligrams twice daily with aspirin for at least 1 year after acute coronary syndrome, and especially after stent implantation. So I think I'll stop here. And if there are any questions, we can take them for discussion. Thank you.
Thank you, sir. There is one question in chat box. Dr. Mohan Pathak sir has asked, can you just elaborate repeat difference between the prasugrel and ticagrelor?
Yeah, so see, both are newer antiplatelet agents. Out of this, prasugrel is a prodrug, whereas ticagrelor is a directly acting drug. Both have got a very rapid onset of action within half an hour, but prasugrel has a high risk of bleeding. And this high risk of bleeding, especially in certain subset of patients, like patients who weigh less than 60 kgs, patients more than 75 years of age, these two are the relative contraindications for using prasugrel. And also patients with prior history of TI or stroke are absolute contraindications for using prasugrel. So whenever you're using prasugrel, you have to be very careful that the patient does not fit into any of these three categories, because these are the relative or absolute contraindications to using prasugrel. Also, studies with prasugrel have shown that in patients who are medically managed, there is no benefit. In fact, the bleeding risk is higher with prasugrel as compared to clopidogrel. So in patients who are, for instance, when a patient gets admitted with an acute myocardial infarction, you do an angiography, you thrombolize the patient, you do an angiography, and the artery is open. You need not do angioplasty. So he is for medical management. In such type of patients, you must not use prasugrel, because prasugrel has been found to increase the risk of bleeding and has not been found to be beneficial than clopidogrel. So in this situation, we either use clopidogrel or better still to use ticagrelor. So these, I think, are the differences between ticagrelor and prasugrel. And but in clinical practice, we usually only more or less use ticagrelor across the spectrum of patients with acute coronary syndrome. It can be used in patients with STEMI, non-STEMI, whereas prasugrel is a cath lab drug, so it has to be given only after the patient undergoes an angiography. Now, why is that? Because, if a patient gets admitted with non-ST elevation MI, they can have triple vessel disease. So many times we have seen that we take up the patient for angiography, we find triple vessel disease, and now he has to go for bypass surgery. And if the bypass surgery is urgent, and if you have already loaded the patient with prasugrel, then the risk of bleeding during bypass surgery is very high, and you may have to wait for at least 7 days. That's why if at all, we need to give prasugrel, we give it only if the patient is very sure to be taken up for angioplasty. On the other hand, ticagrelor can be stopped within 3 to 5 days if the patient has to go for surgery. So I think these are the differences between ticagrelor and prasugrel.
Thank you, Raju sir. I think there are no more questions in chat box, so we can conclude your talk. Thank you, sir, for your very much elaborative presentation on the ticagrelor role of ticagrelor up to 4 years, especially 90 milligrams for 1 year, and after that 60 milligrams BD for another 3 years, and how to mitigate the risk of bleeding versus the thrombotic risk. So I request Dr. Variani sir to felicitate Dr. Rajiv Sethi sir.
Thank you, Dr. Rajiv Sethi sir, for an excellent presentation. Please accept our token of appreciation, IMA Uparna.
Thank you. Thank you very much. Thank you very much, Dr. Varian.
IMA Pune diary also. Thank you very much, sir.
Thank you. Thank you very much.
Thank you, Variani sir. Thank you, CT sir. Just to conclude, to give votes of thanks. Thank you all speakers, Dr. Harshay sir, Phadke madam, Dr. Somani sir, Dr. Ganesh Gaurawala, Dr. Rajiv Sethi sir, Dr. Sumit Agarwal sir for their excellent talk. I thank all delegates for joining online for this webinar. I thank the MMC observer, Dr. Kiran Kharat sir, for even he was present throughout the webinar. I thank Deepen for his technical support, and from bottom of heart from Pune IMA, we thank AstraZeneca for providing this platform for giving the opportunity for this webinar. Thank you, everybody.